Good afternoon. I'd like to call the February 7th, 2019 regular meeting of the CalOptima Board of Directors to order. And I'll ask Mr. DiLuigi to lead us in the Pledge of Allegiance, if you would, please.
To the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
And Madam Clerk, would you please establish a quorum?
Dr. Yost?
Here.
Dr. Katibi?
Here.
Ms. Berger? Here. Mr. DiLuigi?
Here.
Supervisor Doe is on his way. Dr. Nguyen?
Here.
Mr. Penrose, I believe, is on his way as well. Mr. Sanchez?
Here.
Mr. Schofel? Supervisor Steele? We have a quorum.
And just as a reminder, this meeting is being live streamed on the caloptima.org website. With regard to public comments, forms are available at the back of the room. To speak on an item, please complete a public comment request form identifying the item and submit the form to the clerk of the board. To speak on a matter not appearing on the agenda but within the subject matter jurisdiction of the CalOptima Board of Directors, you may do so during public comments. Public comment request forms must be submitted prior to the beginning of public comment, the beginning of the consent calendar, or the reading of individual agenda items. When addressing the board, please state your name for the record. Address the board as a whole through the chair, and comments to individual board members are not permitted. Speakers are limited to 3 minutes per item. Presentations, we have a presentation to our departing Dr. Richard Helmer. If you'd come on down to the front, we would greatly appreciate it. Please join me in honoring Dr. Richard Helmer, who served as CalOptima's Chief Medical Officer from 2013 through 2018. In that role, he oversaw all of the medical care delivery systems, policies, and procedures. And this was actually his second stint with CalOptima. He was involved at the outset in helping to launch the organization way back when. As CMO, he led clinical operations, utilization management, case management, long-term support services, behavioral health, enterprise analytics, and PACE. While his accomplishments in these areas are many, I'll highlight just one, and that's the PACE program. Dr. Helmer was really singularly involved in getting that program off the ground, seeing to its quality, and seeing that it actually functioned and became financially viable and a great benefit to our members. He worked to expand the alternative care setting model, and under his leadership, PACE has demonstrated a proven record of quality care, helping OCs frail senior citizens maintain their independence and allowing them to stay in their homes but still have a place to receive their medical care. A consummate professional and dedicated advocate for quality health care, Dr. Helmer has served as a surveyor for the National Committee of Quality Assurance, NCQA, for 22 years and serves on the organization's Review and Oversight Committee. And under Dr. Helmer's leadership, CalOptima has been an NCQA accredited health plan and has been the top-rated Medi-Cal plan 5 years in a row. Good applause for that. Thanks. And while this is great for CalOptima, this recognition really highlights what is most important, and that is to the benefit of our CalOptima members, those who we serve. Dr. Helmer, on behalf of the CalOptima Board of Directors and all of our staff, I want to present you with this rather giant crystal here. Just on a personal note, I just want to thank you. I've always appreciated your professionalism and your dedication to quality care. It makes it a lot easier from the board when you have a physician who knows what he's doing, knows the population, knows the organization and how it works, and you're able to function in that area. It makes our lives so much easier, so thank you. Thank you. Cool. You want to say a few words?
Well, are you ready? No, I hate to follow that, but I do have a few things I'd kind of like to say. Actually, this is my third. I had 3 stints at CalOptima, and I didn't mean to sort of contradict you, Dr. Yost, but so there's just a couple reflections I'd like to share with you at probably my last board meeting, although I may be back to and sitting in the back of the audience. And I think one of the first things that I noticed what brought me here, I was joining Orange County Medical Association, OCMA, and I had a meeting with Dr. Pete Anderson, who was one of the first board members. And he said, he looked at my resume and my background. He says, we're working on this program for managed care and Medi-Cal. And I thought, wow, I mean, if there's an anathema for organized medicine, managed care, and Medicaid, Medi-Cal, that was really amazing for me. But as I began to see, they said it was going to be a county organized health system, and this was in '94, and everyone was behind it. The Board of Supervisors actually approved the enabling statutes. Hospitals, physicians, medical groups, IPA were all behind it, along with the OCMA. And that was really something that I was really impressed with, that collaboration. Sure, there were differences, but people were generally working together, and I'd really never seen that on this large a scale with that. There was competition. It was good competition, but it raised our game with it. So I was really impressed with that. So better together is more than just a slogan. It's really what brought CalOptima together and what's kept it going on. The second thing is the complexity of Medi-Cal. And there's the aid categories, all of the carve-outs, all of the different agencies we have to deal with. And I remember in '95, the group before we even started, we had a call with the San Francisco office of HCFA. And I had been with FHP before, which was, along with PacifiCare, a pretty big Medicare player with that. But, we just kind of almost ignored the Medi-Cal side of it because it was so complicated, and we just paid for those benefits. But now that I was on the Medi-Cal side, we wanted to know more about that. I have to tell you, after that call, we had more questions, and we were really, it was almost depressing to see that sort of all of these benefits that were disassociated, and it was not good for the beneficiaries, wasn't good for the payers with this. And we all thought this could be something different. Well, it was almost 20 years later, but OneCare, the dual demonstration, came into being. And I tell you, there's been a lot of that through CalOptima. There's been the carve-out, the CCS, which will be, hopefully pretty soon, will be the whole child model. Look at behavioral health. We never had a benefit, but now that's gradually in a single spot. We're able to coordinate those services. And LTSS, it used to be fragmented. It's a single program, including PACE. And thank you. It was dear to my heart and my clinical heart as well to go over there every Friday afternoon and see those people playing bingo and doing whatever, and then have our meetings. So the people in Orange County are truly fortunate, I think, to have these services. And it was, I think that's been a really benefit of CalOptima to be able to bring all these programs together in a more coordinated fashion. Finally, I've spent most of my professional life in the private sector. I was in practice. I've been with several publicly traded companies. I've worked with a lot of talented people, but I don't think there's anyone that's more experienced, harder working, more dedicated to the mission, and a better steward toward the public funds than the people at CalOptima. So it's truly been a pleasure to be working with the people at CalOptima and all of the people that have made CalOptima, the networks, the IPAs, healthcare agencies, all of the stakeholders, and I really appreciate that. So I'm looking forward to watching this next, to continue with that, all the things that has made CalOptima. And I want to thank you for the rock, but I also want to thank you for the opportunity to be part of CalOptima. Thanks. Okay, now back to work.
Dr. Helmer. Michael, would you like to highlight any items from your CEO report?
So good afternoon, Chair Yost, members of the board. Just to set the stage, I'll highlight some of the items from my written report. including some status updates on different board-driven initiatives, some of which appear on today's agenda. So just to start, preparations for the July 1 transition date to the whole child model continue. As you know, in November, DHCS released network adequacy standards for our delegated health networks. The standards require that each network have 23 different types of CCS paneled pediatric specialists and other providers. Our health networks have responded quickly to the revised standards by finalizing contracts and letters of intent. And in January, DHCS gave preliminary approval for all of our delegated health networks to participate in the whole child model. So that's really good news. In terms of next steps, by March 1st, CalOptima must provide DHCS with signed contract pages between the health networks and all of the CCS paneled providers as confirmation. And DHCS will provide final approval of our delegated health networks that are permitted to participate in the whole child model by March 15th. Transitioning last week, the Orange County Board of Supervisors approved a $16.6 million investment for the Be Well Regional Mental Health and Wellness Campus. This joins your board's commitment of $11.4 million for enhanced services for our Medi-Cal members in the new facility, as well as $12 million in commitments from Kaiser and Providence St. Joseph Health. So the $40 million campus aspires to create a new approach to mental health care that brings together a range of services, and construction on the 60,000 square foot facility is slated to begin in the spring. I don't know, Supervisor Doe, if you'd like to add to that as I pause.
Sure. Thank you, Michael. First of all, let me apologize for not wearing a coat. I rushed out in such a hurry, I forgot my coat. So, secondly, today, if you look at the editorial section in the Register, there was a very good opinion piece on the Anita Drive facility that Michael just described. And I agree with the editorial board for the Register that Anita Drive will come to represent the model in which the nation will follow, to have public-private partnership and many stakeholders in the community to come together for a joint solution. Now, for many of you who may not be involved day to day on that issue, let me share with you why it's so revolutionary. Up until now, we have always treated our patients right within our bandwidth. If you're privately insured, you go to one set of doctors or hospital. If you're a CalOptima, or if you're the county, if you're moderate to severe, then you go through the healthcare agency. No longer. With Anita Drive, there's only one place that patients go to. And then we are payer agnostic, and we'll deal with the billings later. And so we put the care as the primary focus. And we believe anything from crisis management to longer residential treatment in one location is going to make, with an FQHC, some medical services provided there as well. That will eliminate a lot of the redundancy and inefficiency of transporting people to the ER just to get a Band-Aid and then come back and get mental health treatment. So over the whole course of treatment, I believe is going to save the system as a whole, not just the private insured or the state or the CalOptima, a lot of money. And going forward, that will also allow us to be an integral part, we, CalOptima, be a part of the system of care, whether it be homelessness, mental health, or the regular patients that we have. So I want to, on behalf of the Board of Supervisors, and I sit on the board for Be Well OC as well, thank you, CalOptima and the board and staff for your work in supporting this concept. Thank you.
Thank you.
More good news. Last week, the Orange County Board of Supervisors approved the 2019 appointments of supervisors to the various boards, commissions, and committees. Supervisors Doe and Still were reappointed to continue to serve on the CalOptima Board of Directors, and Supervisor Chaffee was appointed as the alternate. Homeless health, staff have been focused on homeless health. A gap in serving the homeless is physical health. The traditional healthcare system where the patient must go to where the doctor is doesn't necessarily work well for the homeless population. Reasons can include sort of obvious reasons: transportation, belongings, pets, and behavioral health. So staff are evaluating alternate approaches, including enhanced transportation, mobile clinics at shelters, and clinical field teams. So on today's agenda, as an information item, this item will be addressed with your board as we sort of introduce this item of clinical field teams. And staff, after getting your reaction and your input, plan on coming back to a future meeting with a recommendation. Transitioning, your board asked for an evaluation of our provider delivery system. And today, staff is returning with the results of the RFP based on the statement of work that was approved by your board. So pending approval by your board today, next steps would include a contract execution with the board-approved vendor, followed by approximately 3 months, April, May, for the selected vendor to complete the work. And then we would hope to come back to your board at the June meeting with the initial results. And then related to PACE expansion, the 3-month window for outside PACE operators to submit request for letters of support from CalOptima closed last week on January 31st. 2 PACE organizations submitted request to open and operate PACE centers in Orange County independent of CalOptima. Staff will evaluate the request based on criteria that was approved by your board in April. And we hope to come back with a recommendation at the April meeting. And then last, today's agenda includes 4 information items for which staff plan to give presentations. And so the 4 are marketing, homeless health, which I mentioned, our 3-year strategic plan, and DMHC's proposed licensing regulation.
Great. Thank you, Michael. Supervisor Doe.
Michael, you can sit down. Just a quick request. The health homes program, I know it does involve dealing with a homeless population, which blends into what we just talked about with the Anita Drive facility. It would be probably beneficial for the board if maybe your staff can do a presentation on what that program involves, because there are multiple components to it. It can be pretty complex because some of the responsibilities that will be expected of CalOptima going forward, and we will be asked to make decisions on a system of care based on that knowledge. So it would be good to bring the board up to speed.
Happy to bring an information item to the next meeting.
Is that okay? Yeah. Okay.
Okay, with the
Of
chair.
course. Yeah. Okay. And public comment, Madam Clerk, were there any requests for public comment other than item 23?
No request for general public comment.
And the consent calendar, for the record, all consent calendar matters are approved in one motion unless pulled by a board member for discussion or separate action. Are there any motions to pull an item from the consent calendar?
I'd like to pull item 3.
Item 3 will be pulled. Okay. Anything else? Okay, I'll take a motion to approve the balance with the exception of item 3.
So moved.
Okay, moved by Mr. Schoeffel, second by Dr. Katibi. All those in favor say aye. Aye. Okay, all those opposed? Seeing none, that passes. And then item 3, how do you want to have a report, or do you want to just make your comments about it?
Just a comment. Very much in support of this item. I have no issue with what was submitted. I just want to reinforce, I think it's long overdue for us to have a strategic plan for population health. And I know also in the updates that you've been giving us, Michael, you're preparing us and CalOptima for a renewed strategic plan as our current strategic plan expires relatively soon. I would just love to see this incorporated into it as we proceed into the future. And population health management is such an important thing in this field, in the industry, and in Orange County. And I really see CalOptima being a leader in population health. So I would move approval.
Okay, so moved by Mr. Penrose, second by the chair. All those in favor, say aye.
Wait, may I?
Oh, yes, you want me to comment? Sure.
I support the item. I just want to ask staff to try, because I read through the report, and I would like to ask that staff incorporate some of our findings in the community assessment in terms of the ethnic communities, and weave that into your efforts so that we can reach the population that may be underserved. So make that a little bit of a focus. That would be great.
Other comments? You have a motion and a second. All those in favor, say aye.
Aye.
Any opposed? Seeing none, that passes. And then reports. Madam Clerk, would you please read the item?
Number 6, authorize the Chief Executive Officer with the assistance of legal counsel to enter into an agreement with Health Management Associates for consulting services to provide data analysis and to perform a market survey related to the CalOptima Provider Network Delivery System pursuant to the attached scope of work, and authorize expenditure of unbudgeted funds in an amount not to exceed $250,000 from reserves to fund the agreement.
Okay. And for the record, Director Schofel is not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. Are there any other potential conflicts?
I just have a question.
Sure.
So this scoring system, it seems like our score seems very similar. I mean, it's not really that much difference between first and second. What's the scoring system we used, and what was the reason that there's a difference here, between Pacific Health and HMA?
Largely the number of hours, but go ahead. Do you want to answer that, Michael?
Sure. It's just looking at the scoring sheets. The scoring was based on first their written proposal, so I guess the quality and completeness of their proposal. Second was the knowledge of the industry, the qualifications they have to do the analysis, and or do they have capacity to handle the scope of the statement of work. Third would be their experience doing this type of work. Fourth would be the account team that they would bring to the project, and the fifth was price, and sixth, and then the last was the contract changes, meaning once we choose a vendor, we have to execute a contract with them. So we always include the template CalOptima contract, and we say, would you require any changes? And so that's part of it. If a vendor says they're going to need, dozens of changes, then we might, that would be a consideration. That's on the written evaluation of their proposal. Then there's the interview scores, and the components, the scoring components for the interview part were the account team, the knowledge of the industry, public agency requirements, the statement of work, the different components of the statement of work, the project management team, and then the overall presentation.
So
And-
what made the difference between this less than 1 point score difference?
I would say the number 1 and 2 vendors, it was at the end of the day, they were very similar, almost a tie. I mean, you can see it was a 1 point difference. And someone asked, because one vendor was higher in price than the other.
So what's the price difference that makes it?
Was a
makes
price difference,
for
yeah,
one score?
yeah.
The price difference was largely the number of hours. I think the hourly rate for the second one was actually slightly lower than the hourly rate for the one that was ranked slightly higher. But the second potential vendor put in a lot more hours than the first one did.
When we just
To
one
that
more.
point, Mr. Chair.
Yes.
Michael, is one of the two numbers, it seems like they're different. Is one underestimating the work and one overestimating, or which one is more realistic?
So the second place vendor, while a much higher price overall. So The first place vendor was 200,000. The second place vendor was 400,000. But the second place vendor actually had a lower hourly rate, but had estimated it would take twice as many hours. Okay, so a lower hourly rate, but twice as many hours. But the evaluation team based it just on price.
Yeah, but
But is it's hard to say, is one underestimating, is another overestimating? I think the second place vendor saw that to do a more thorough job, I think it's going to take more hours. That's how they estimated it. They both got the same statement of work. There was the same interview process.
I would
So
love to
before
hear from some of the
yes.
administrators here.
Well, yeah, we'll go, yeah, so Lee, you had some comments? Go ahead, you can go next, and then
Mr. Chair.
Ron will be after you.
This got my attention as well. Obviously, this is a topic that, as a board, we've all been very focused on, and the results of the RFP coming in this close really makes you stop and think. And in my mind, in looking at, so I spent a little bit of time with Michael talking through the same things that we've just talked about, and some of the details of the RFP and how close to a virtual tie is this? And it feels to me like there's enough subjectivity in some of the scoring that it really is a virtual tie, especially with the price consideration. Estimating the number of hours and having that big of a difference, I'm not sure that either vendor has the ability to perform what we're doing in half of the other one's hours, or that it would take double. And I think that we can put some level of control on that. As I'm thinking this through, both of these vendors are highly respected from everything that I know.
Right.
In the industry. I do know that the vendor that scored the highest does have some former senior leadership from CalOptima that's involved with the vendor. In fact, they would be involved in this engagement. And there are pros and cons that go with that. On one hand, they know CalOptima very, very well, intimately, and they could take that intimate knowledge to guide us. And to really springboard off of the work that they had done with us previously. On the other hand, the second vendor, it would be interesting to get a completely fresh perspective. And my understanding, I know Milliman's reputation is without question. And I don't know the principal that would be involved here, but I do understand that he comes highly regarded and with a strong reputation. And so I don't think it's a question of difference of expertise, but the inside familiarity with CalOptima versus complete understanding of our industry and other codes and plans in the state and workings of the state without the inside knowledge. I would be honestly concerned if we introduce a level of bias, even if it's unintended, and I want to be careful how I say that, because the people that are involved with the first vendor that used to work at CalOptima have complete integrity in my mind. There's no question about that. But they also have pride and ownership. They were at CalOptima. They helped to design what it is that we're wanting to review right now. And could that introduce some level of bias that nobody would even, really realize in a substantive way? But could that get in the way? Another layer on that is then, based on this report, we may or may not take action. We may or may not decide to follow up on the information in the report. And if we do decide to take action, there could be winners and losers. Could some people affected by those decisions start to come back now and question a decision that we made today without even thinking ahead about what those decisions might be? And so my feeling on it after a lot of reflection is that it would be better to avoid the level of potential issues that we could get ourselves into, and to go with a vendor that has no inside history with CalOptima. So that's kind of my thinking.
Mr. DeLuigi, you're up next.
Thank you, Mr. Chairman. Well, both of these, as Lee said, these are both highly regarded professional organizations that I think would do good work for CalOptima on the project. The thing that I want to call out again today, and I did at our last meeting when we went through this, and I remember Supervisor Doe was helping to kind of tee some of this up as well, given his involvement in this project and its importance. But one of the things that I raised was the desire that this effort have a level of breadth beyond what I saw in the scope of work that day. And as I go through it here, I don't, and I went through that, but I see no change. So what I wanted to clarify is this, because when I think about these two players, one thing that I'm very interested in is their past national engagement. That is, as a result of some of their things, what awareness and knowledge do they have of some pretty innovative systems out there across the country in some of the areas we're talking about here. The concern I have is the way we talk about some of these things is a bit narrow, and that's what I was raising last week and requesting that we, or last meeting and requesting that we broaden. So for number 5 as an example, the requirement says review current and assigned criteria and model, including survey of other Southern California health plans criteria model. And Southern California health plan models is important to me. California is important to me. But I also think that there's some activity going on across the country that would be helpful and beneficial for us to be able to have benefit of their previous engagements and knowledge. So an important factor to me as I look at these two is which one staff believes has the strongest national engagement that might bring that to bear. But I'd say that with regard to number 5. I'd say it with regard to number 6, which talks about payment methodologies. Well, there's a lot of things that are going on out there, which would be good to develop the network performance evaluation tools, same thing. Also number 8, the other county organized health systems and local initiatives, that's fine. Delegated versus non-delegated models. Again, I'd like to hear what some of the practice leaders, some of the best practices out there in other areas of the country too. And number 9, particularly as it relates to member satisfaction, because we've got this unique situation, particularly here in California and maybe in the West. And I'm aware more of the CAHPS scores, but they are particularly low, California and the West. And it would be good to know that knowledge of what's going on elsewhere may help us understand that, well, that may not be a problem. Maybe there's a reason for that, or maybe there's other factors. And then finally, the development of administrative costs as well. So those are the areas that as I look at our current scope of work, mainly because we specify pulling from local or Southern California, et cetera, I don't want that scope of work to restrict what we may be able to get from a very qualified consultant who does a lot of national work and can bring awareness of those practice leaders and those best practices out there to us regarding the questions we're raising. That would be very helpful to me, to us as a board, I think, in assessing the data that we get when all is said and done.
Mr. DiLuigi, what do you want to do? Do you want to change the scope of work, or are you interested in knowing which of these top two that are very, very, very close? I think the board is definitely on firm ground in choosing either one, whatever we choose. Do you have a feeling that one of those two has a greater national level of experience?
No, I need help on both.
Okay.
I raised this previously because I wanted the scope of work to be broad enough to consider that national factor, which I think is important for us. So I don't know if staff can assure me, the board, that they can, in fact, access and work with whoever we select to make sure that that firm's knowledge is brought to bear on the data we collect, and so that we're aware of best practices, et cetera. That'd be one thing.
Right.
Otherwise, I would want to change the scope of work if it's going to endanger this to be unnecessarily narrow. But with that assurance for myself and the board, I think I'd be fine. And then the second is because of the it's less than a point difference in the score. As I said, that's an issue with me. Michael, staff want to weigh in on whether one of these versus the other may be a little bit more skilled, adept, rich in their information and knowledge and previous engagements on the national scale. I know that bringing Milliman to the equation is a positive for Pacific Healthcare. Milliman's got very definite national exposure. But I'd like to hear your perspective on those two as it relates to the specific issue that I'm raising.
Go ahead, Michael.
So I think on the first, the statement of work that both firms have a national footprint. Both firms do work outside of California, both vendors. So we could allow for some additional hours so that they could include that national information. So I think that works with our statement of work, and we could work with whatever vendor your board selects to cover that.
So
You're not going to weigh in on which one is maybe more so. All right.
well,
Oh, hang on one second. One at a time. Next, Supervisor Steele, go ahead. You have a question?
So this work plan, it's been already approved for a few months ago. So, we just followed the work plan that we already approved that. So now the bottom line is first top two are almost same numbers. And I totally agree. So one company has ex-employees that, who know about the CalOptima, and they already know the plan and, the programs that what we have. Second company has totally independent and new idea coming in. So I want to hear from Michael that, what's better to have one of these two, because since they are so similar and the numbers are not that much different. So, what you think that it's better to bring one of the company in to work with. I think, as I agree that new idea coming in and totally brand new company, that might be really good to look at the fresh perspective of the CalOptima. So that's, what's my thinking too. I didn't want to mention about ex-employees and stuff because I already heard about that. But, since we openly talking about it, so I just want to hear from your feedback about that. What's better way to that improve the CalOptima? Which consultants, companies are better here?
So I think we can't go wrong with either one. I think they're both really good. I think HMA, what HMA brings to the table now, HMA is national. They're headquartered in Michigan. It's just that the HMA folks we know are all in California. A lot of them are in Costa Mesa. And those are the folks I think a lot of you on the dais have had relationships with, and even the county has used HMA. So I would say what HMA brings is they bring people to the table that certainly know CalOptima, that know the other Southern California plans, and that have some pretty good insight into kind of where the state's going. I would say what the Pacific Health brings to the table is I think Tim Riley. He's was the CFO at LA Care for more than 5 years. He helped onboard the CFO at the Inland Empire. The Inland Empire Health Plan and LA Care use him a lot. And he consults for the state on a lot of different initiatives, including directed payments. He helps the state design a lot of the initiatives that impact all of the plans, Medi-Cal managed care plans, including us. So Tim Riley has a really extensive relationship and is someone who, if you asked, where's the state going, what's another plan doing, he's someone who could probably answer it standing here at the podium. I think what Pacific Health doesn't have, which is why I think part of the reason is you see they're partnering, is they don't really have that national footprint. Pacific Health is definitely specific to, I would say, California. They probably have some clients outside, but I would say the majority of their business over the years has been California. And so we all know Milliman. Milliman is definitely national. They're in so many different states. They do a lot of actuarial work. And so Milliman would have a lot of depth, in terms of not only what are the models, but what are some of the specifics around the models and how have they been successful or not in different parts of the nation. I think Milliman would have a lot of depth, I would expect, in that area. So, that's why it was so difficult, and I think the scores were so close, is because they're both really good vendors.
So now that you've gotten a definitive answer to your question, Supervisor Steele, are there other board members who have questions? Supervisor, Director Nguyen, please.
So coming from a person that had no sort of understanding to either of these organizations, the point totals, as we all agree, are pretty equivocal. I think that price was one of the criteria, and so if you actually accounted for that confounding factor, the point total might be even closer. And I think, kind of hearing the board a little bit and, hearing from Lee and, it got me thinking prior to the board meeting as well after the debrief with Michael. And I think Supervisor Doe can kind of speak to this, but I think the initial intent, if I understand it correctly, was to get a fresh perspective, to get a highlight of what things we don't know about our system and to see our blind spots. And, with that said, I think that having an organization that knows little about CalOptima might be very beneficial in this sense. And, we know what we know, and we don't know what we don't know. And we really need an organization to come in to tell us, what things are going on without an intimate understanding of CalOptima, I think. And, that's the intent of this going forward. I might be wrong with it. I kind of want to hear other board members, but I think because the scores are so equal, I'd venture to say that, we should go with the organization that can bring us new insights.
Other board members, comments? If not, I'll entertain a motion. Okay. Director Penrose, go ahead.
Thank you. I do think, although we're trying to look at the price issue and identify that you can look at it both ways, I do think the total price was, a question, does raise a question, $200,000 versus $400,000. So I would propose, if we go with Pacific Health, putting a limit on the total engagement. The COBAR suggests a $250,000 allowance, which I would support. And I'd go ahead and make a motion to go with Pacific Health with that caveat.
I will second that motion, but may I suggest to not make it a hard cap, that if they have a articulable reason why they may need to go beyond the 250, because their estimate is at 400,000, and that's why I asked earlier the number of hours. That's such a big disparity between the two. And I agree with you. You teed up the item perfectly, and I agree with your motion. But I would just ask if you can modify your motion, so if they need to, that staff can bring it back to the board for us to consider.
That's fine with me.
Can I?
Go ahead.
We want to make sure we cover Mr. DeLuigi's, ask for, that we make sure this gets a national sort of scope. So I would ask that we just bump it up a little from 250 to cover that national part, not because we might be going with a different vendor, but just to make sure we include everything in the analysis that your board is wanting, so that we allow for those hours.
Do you want to,
So-
do you have a suggested amount? 300 and 350?
300, and then if we start approaching 300 and it looks like we're going to go over, we would come back to the board for authority.
So the motion of the make of the motion, if you want to modify that.
Is that you consider that a friendly amendment?
Yes, I do.
Okay,
I
so
can restate, but I know we have an outstanding clerk of the board who
yeah,
probably got
let's
all
look
that.
at the motion straight, and then we'll do comments. So the motion would be to go with Pacific Health up to 300,000 with the provision that we would come back to the board if it's to be higher than that. And we have a second from Supervisor Doe. Okay, and then we have some comments. And Mr. DeLuigi, you have
Thank you.
comments.
Thank you. And thanks, Michael. I appreciate that add-on too. But what I might suggest is, obviously, we're not going to be willy-nilly when it comes to price. We're going to be stewards. But I think that I'd want to make sure that we not be outrageously overbearing in terms of, and I think what you're talking about makes sense. But maybe another thought is, when you do in fact go back to whoever we select, making that clear, and if there are significant elements that they would suggest to you they might carve back on, maybe that's something that should come back to us.
Okay.
If it's, I mean, again, to me, it's a question of how important is it to us? We're willing to spend the money. But knowing if they're looking at it and saying, oh, we can manage within that and we think we can handle it, that's great, we're fine. But if they say, well, that means we're going to have to potentially carve back here or there or wherever, be something we might want to be aware of.
Okay.
I would think.
Okay, I think that's very reasonable. Doesn't require change to the motion. So you have a motion and a second on the floor. Are there other comments of the discussion? All those in favor of the motion, please say aye.
Aye.
Aye. Any opposed? Seeing none, that passes. And Madam Clerk, would you please read the next item?
Ratify amendment of CalOptima's contract with Med Impact for pharmacy benefit manager services to begin collecting Medi-Cal prescription drug rebates for utilization incurred effective October 1st, 2018.
Okay, we have a motion by Supervisor Doe, second by Supervisor Steele to move the item. Is there discussion? And first of all, for the record, Director Schofel is not participating in this item due to potential conflicts of interest and will leave the room during the discussion vote. Are there any other?
Yeah, I have a question, Mr. Chairman.
Please, go ahead.
Where you're going with this, and again, it's pretty straightforward. Seems pretty basic. The question I have, though, is, it took the state 5 years after the passage of this thing, and suddenly they're doing it. Now, there's a lot going on right now. The state is going to carve out prescription medications and pull it all back to the State Department of Healthcare Services and look for the value of scale in terms of negotiating. And then you got a lot going on at the federal level, too, in terms of these safe harbors for these discounts blowing up, potentially. And we'll know that pretty quickly here. So, I mean, as long as your thinking is we're not going to get something big started here at a significant cost, and then it gets done away with, or again, affects our program administration.
So I think this is a pretty modest additional requirement for Med Impact, given that they already collect rebates for a number of other clients for commercial plans and
They'll do it all.
whatever's the
They'll
status.
do it all for us.
So-
We're
so-
not going to have to add resources or anything like that.
Okay.
It's strange timing, though.
It is. It's peculiar that, yeah.
Yeah, and basically, this involves a change implemented by the state in terms of who collects rebates from the drug manufacturers and prescription drugs, and it's now shifting to CalOptima.
Yeah, just took
as
them
opposed
5
to
years
state.
to do so. Yeah.
Okay, so we have a motion by Supervisor Doe, second by Supervisor Steele. Any further discussion? Seeing none, all those in favor? Aye. Any opposed? Seeing none, that passes. And Madam Clerk, would you please read the next item?
Authorize the Chief Executive Officer with the assistance of legal counsel to enter into contracts at the equivalent of non-contracted Medi-Cal rates with in-area and out-of-area hospitals, providing Medi-Cal covered services to CalOptima Care Network, CalOptima Direct, and Shared Risk Group members to facilitate the payment of Department of Healthcare Services hospital-directed payments, and authorize retroactive effective dates as far back as July 1st, 2017, solely for purposes of the state's hospital-directed payment program and to the extent permissible based on guidelines set by the Department of Healthcare Services.
And for the record, Director Schofield is not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. And Supervisor Doe is not participating in the discussion and vote in this item due to potential conflicts under the Levine Act. Are there any other conflicts or recusals? Okay, seeing none. And Michelle, would you please briefly introduce the item?
Yes, absolutely. Good afternoon, Chair Yost, members of the board. The state of California had a program that was known as the Hospital Quality Assurance Fee, or QAF, which provided payments to hospitals based on regulatory defined criteria. CMS instituted the final rule, which required changes to the current California payment methodologies. Included in the change was requirement for hospitals now to maintain contracts with Medi-Cal health plans in order for them to be able to receive their enhanced payments. So in the past, non-PAR hospitals would receive the QAF regardless of their contractual status. I see this as very positive. Following these changes, DHCS implemented what they now call a hospital-directed payment program to meet the new CMS requirements. The effective date of this program is retroactive to July 1st, 2017, and for hospitals to receive payment under this new program, they must maintain contracts with managed care plans, and that's now required. So this COBAR provides opportunity for those hospitals to contract with CalOptima to participate in this directed payment program retroactively from the effective date. It also allows in-area and out-of-area hospitals who provide a limited scope of services for CalOptima members to also receive supplemental hospital payments per the new CMS requirements. We believe this COBAR shows that CalOptima is a good partner with our hospital providers who do continue to make care accessible to all CalOptima members. Any questions?
Questions of staff?
And I just have a question here.
Sure. Supervisor Steele, go
regarding
ahead.
Levine Act. I want to ask our legal counsel that this is a blanket authority that we are giving. So we are not giving specific hospitals or any facility that any authority here that they can just apply it for their payment through CalOptima, and we are giving them authorization here, right?
That's correct.
Okay, so thank you.
Other questions of staff?
Just a quick comment. I agree, Michelle, with your comment that this is a good symbol of the partnership between CalOptima and our hospital community. And I appreciate your willingness to move forward on an initiative like this. And it's also, I believe, very similar to something we approved at our last meeting, which was for out-of-county hospitals.
Which didn't have quorum, so this is actually a continuation of that.
Okay.
So we haven't implemented it yet. We were waiting for this meeting.
So we were about to approve it. That's right. Thanks for the reminder.
It actually received positive reviews last time as well.
Okay.
Anyway, I want to be known that I fully support this. I'll make the motion.
Okay, motion by Director Penrose. Is there a second?
I second.
Okay, second by Director Steele. All those in favor, please say aye.
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 Any opposed? Seeing none, that passes. Item 9, Madam Clerk, would you please read the item?
The Chief Executive Officer, with the assistance of legal counsel, to enter into an amendment to the January 1st, 2019 Whole Child Model Memorandum of Understanding with the County of Orange to reflect CalOptima's new implementation date of the Whole Child Model Program, and enter into an amendment to the coordination and provision of public health care services contract with the Orange County Healthcare Agency to reflect changes related to the Whole Child Model Program.
And for the record, Director Sanchez is not participating in this item due to his relationship and his position at the Orange County Healthcare Agency and will leave the room during the discussion and vote. Director Schoeffel is not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. Are there any other abstentions or recusals? Okay, seeing none, Michelle, would you please introduce the item?
COBAR is to amend the contract with the Orange County Healthcare Agency to reflect the changes related to the Whole Child Model Program. Since the implementation date for the Whole Child Program changed from January 1st, 2019 to July 1st, 2019, CalOptima staff is now working with OC Healthcare Agency staff to modify the Whole Child Model MOU and the public health contract to reflect the new DHCS Whole Child Model implementation date. This is to ensure CalOptima meets all the requirements of the Whole Child Model Initiative. So staff recommends approval for this requested action to amend the Whole Child Model, MOU, and the public health contract.
Questions of staff? Seeing none, I'll take a motion to approve.
Move approval, Mr. Chair.
DeLuigi, second by Supervisor Doe. Any other further discussion? All those in favor, please say aye. Aye. Any opposed? Seeing none, that passes. And Madam Clerk, would you please read the next item?
Authorize the Chief Executive Officer with the assistance of legal counsel to amend CalOptima Community Network fee-for-service specialist physician contracts, except those associated with the University of California, Irvine, Children's Hospital of Orange County, or St. Joseph Healthcare and its affiliates, to reflect changes related to the Whole Child Model and other regulatory updates.
Okay. And for the record, Director Sanchez is not participating in this item and will leave the room during the discussion and vote. Director Schoeffel is not participating in this item due to potential conflicts. And, sorry. We're on this, are we?
So,
We're on item 10, I'm sorry. 10. Supervisor Steele is not participating in the discussion and vote due to potential conflicts of interest under the Levine Act, and Supervisor Doe is not participating in this item due to potential conflicts of interest under the Levine Act. Are there any other conflicts or recusals? Yes. Okay.
Dr. Schoeffel is also not participating in this item
Okay,
due to potential conflicts of interest.
Okay, perfect. And Michael, I understand this item and the following two items involve contract amendments to reflect changes to the Whole Child Model and other regulatory changes. Is that correct?
That's correct.
Okay. Are there any other questions?
Move the item.
Okay, moved by Mr. Penrose, second by Director Berger. All those in favor, please say aye.
Aye.
Any opposed? Seeing none, that passes. And Madam Clerk, would you please read the next item?
Item 11, authorize the Chief Executive Officer with the assistance of legal counsel to amend CalOptima Community Network fee-for-service specialist physician contracts associated with St. Joseph Healthcare and its affiliates to reflect changes related to the Whole Child Model and other regulatory updates.
Okay. And for the record, due to my provider affiliation with Providence St. Joe's Healthcare as an anesthesiologist and physician, I will not be participating in the discussion vote on this item. I'm turning over the gavel to the very capable Dr. Katibi.
Sir. Madam Clerk, for the record, also note that Director Schoeffel is not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. Due to his provider affiliations, Director Penrose is not participating in the item and will leave the room during the discussion and vote. And Supervisor Doe is not participating in the discussion and vote on this item due to potential conflicts of interest under the Levine Act. Are there any other abstentions or recusals? Are there any questions for staff on this item? May I have a motion? So moved by Director Dr. Nguyen, seconded by Director Berger. All those in favor, please say aye. Aye. Any opposed? Motion carries. I'll turn the gavel back over to the chair.
Madam Clerk, could you please read the next item?
12, authorize the Chief Executive Officer with the assistance of legal counsel to amend CalOptima Community Network fee-for-service specialist physician contracts associated with the University of California, Irvine, to reflect changes related to the whole child model and other regulatory updates.
Okay. For the record, Director Schofel and Nguyen are not participating in this item due to potential conflicts of interest and will leave the room during the discussion and vote. Supervisor Seal and Doe are not participating in this item and discussion on this due to potential conflicts of interest under the Levine Act. Any other abstentions, recusals? May I have a motion to approve?
Move the recommended action.
Moved by Director Berger, second by Mr. DeLuigi. All those in favor say aye. Aye. Any opposed? Seeing none, that passes. And Madam Clerk, could you please read the next item?
Adopt resolution approving updates to human resources policies and CalOptima employee handbook.
And Loudon, would you please briefly introduce the item?
Yes, thank you, Chair Yost and members of the board. Per your board's request, now we are bringing the HR policies on a quarterly basis for your review. So this COBAR introduces updates to 4 of our policies, minor changes to some of those policies. Those are the conflict of interest policy, education reimbursement, supplemental compensation, and the salary schedule. And these are minor changes to those. For the salary schedule, we are updating 4 positions. Basically, it's a change in title to be in compliance with the NCQA standards. So we are eliminating the old position titles and replacing them with the new one to include the word population health instead of disease management. So those are the changes. And then one final item is our employee handbook. We're also updating the employee handbook to reflect the changes that we have made to the policy that your board has already approved. So those are updated in our employee handbook. And then some other minor changes to the employee handbook that were not necessarily in the policy but are part of the practice or will be updated. Those are also included in this.
Okay. Questions of staff? Okay, seeing none, take a motion to approve. Motion by Director Berger, second by Director Penrose. All those in favor, please say aye.
Aye.
Any opposed? Seeing none, that passes.
Thank you.
Madam Clerk, would you please read the next item?
Ratify Amendment 37 to the primary agreement between the Department of Healthcare Services and CalOptima related to rates.
Okay. And Michael, this is, as I understand, this item involves revised amendment on the primary agreement to the Department of Healthcare Services with anticipated rate changes. Is that correct?
Correct.
Okay. And are there any questions of staff? Take a motion to approve. Moved by Director DeLuigi, second by Director Berger. All those in favor, please say aye.
Aye.
All those opposed? Seeing none, that passes. And Madam Clerk, could you please read the next item?
Authorize the Chief Executive Officer with the assistance of legal counsel to execute an amendment to the HMO service contract with Vision Service Plan to add 1 routine eye exam every 12 months for Medi-Cal members diagnosed with diabetes as an additional covered benefit.
Any questions of staff? Take a motion to approve. Moved by Director Berger, second by Director Penrose. Please, all those in favor, please say aye.
Aye.
Any opposed? Seeing none, that passes. And Madam Clerk, would you please read the next item?
Authorize unbudgeted capital expenditures of up to $43,250 from existing reserves for architectural fees to develop a remodeling plan for the existing member services lobby at 505 City Parkway West in Orange, the 505 building, and ratify $11,334 and authorize $73,666 in unbudgeted expenditures from unspent budgeted funds for an additional security guard at CalOptima facility located at the 505 building.
And my understanding is this is an item that is a recommendation to take steps to improve employee safety. And these recommendations were made by the Orange County or the Orange Police Department. Is that correct?
That's correct.
Any questions of staff? Seeing none, I'll take a motion to approve. Moved by Supervisor Doe and second by Supervisor Steele. All those in favor, please say aye. Aye. Any opposed? And advisory committee updates, provider advisory committee update. Welcome.
Thank you very much. Good afternoon, Chair Yost and members of the board. You have the update report in your handbook. The only thing I also want to mention as well is that we will be having forming an ad hoc committee for nominations for the hospital and nurse representatives. And then also in the future, we will be having a number of open seats that we will be looking to fill as well. So we'll be keeping you updated on that part. And then in addition, we're going to have an ad hoc committee to review the goals and objectives from 2017-18, and we'll be looking to update that information as well. So
Okay, thank you very much.
thank you.
The member advisory committee update? Sally?
Good afternoon, Chair Yost and Board of Directors. We also have presented a written report. So if there's no questions on that, I would just like to add that we do have one open seat, our child's seat. The nominations for that seat currently close on the 15th of November. And we have already established an ad hoc committee to review those applications once the deadline is closed. So nothing else to report.
Great. Thank you very much. In the Whole Child Model Family Advisory Committee, Maura Byron. Welcome.
Thank you. Good afternoon, Chairman Yost and board members. I just wanted to give you a brief update. The update, of course, is in your handouts. And wanted to let you know that we too have an ad hoc committee coming up soon to discuss a new member who will be joining our committee. We have, as you go through the information and the notes that are there, I just wanted to share with you that it's sort of an exciting thing that within the Family Advisory Council, we have a member of our committee who's also a member of the advisory for the Family Voices Committee, which if you read through your update, it tells you that we are presenting and going to be having someone at that representing us there. So that's a good thing. I also wanted to tell you that hopefully in the upcoming future, with all of the information that's going on, this committee is a little unique unto itself because we are comprised of parents of the children who are being served by the Whole Child Model. I myself have a 19-year-old with fully involved cerebral palsy, and she's been a CCS patient for the entirety of her life. And so I'm excited to be here and representing that group. And I'm hoping that over the next few months, we're going to have an opportunity to talk about some of the more pertinent items that are going to affect parents, such as SARS and authorizations and pharmaceutical access and doctors and who's paneled and how long can we see them and transitioning into adulthood and all of those wonderful things. So I look forward to being part of this organization and being available to you if you have questions and here to hear what you have to say. So thank you all very much for your time.
We're here to hear what you have to say. So.
You may be sorry you said that.
All right, thank you. Information items, the overview of marketing efforts. Bridget Kelly, you're on.
Thank you, and good afternoon, Chair Yost and members of the board. I'm Bridget Kelly, Communications Director, and I've been asked to share a brief overview and presentation of our marketing and educational efforts for you today. So starting with a quick background, we are prohibited to promote Medi-Cal enrollment, but we can market our competitive programs as long as we're compliant within the guidelines. So our primary focus of our marketing efforts are, of course, to promote enrollment in our competitive programs. You see them there before you. Healthy Families, which launched in 1998, sunsetted in 2013. One Care launched in 2005, PACE in 2013, and One Care Connect in 2015. Our primary focus of our educational efforts are to improve our HEDIS quality scores, and our key measures that we're constantly trying to improve upon are breast cancer screenings, cervical cancer screenings, immunizations, well child visits, adult visits, and diabetes care. Our focus with our educational efforts, I mentioned already, I'm sorry. There we go. So our considerations, we first look at our target audience, which might be by age, language concentration, etc. We consider the geographic reach or where the media tool is being distributed or aired, all within our budget. For example, the best outreach to seniors might include our resource directories, our newspapers, and radio. We hold internal meetings and work with advisory committees for feedback. We develop our marketing and educational campaigns adhering to regulatory requirements, for example, font size, sixth grade readability level, and language. We craft our messages that meet identified goals for educational efforts to improve those HEDIS performance, as well as in response to member health needs assessment and CAP annual findings. We take a look at those, of course, as well. And then we have our team design concepts and write copy for review. We meet internally with various member-facing departments. I've bulleted those prominent folks that we meet with to get our feedback on the campaigns, and we also do that to keep them informed as to the timing and tactics of our campaign. We have field tested our concepts with both members and community members in our satellite office at the County Community Service Center. And last fall, as you know, we began sharing our marketing and outreach schedule for the current month and the month ahead to your board. CalOptima does use a multifaceted approach to reach our target audiences, and we market using multiple vehicles, including print ads in various newspapers. We've listed a few there, magazines, resource directories. We use outdoor ads, and that's digital and traditional billboards, OCTA buses, transit shelters, storefront promotions, for example, in markets and laundromats and beauty salons and nail salons. Those storefront promotions are fairly new for us. Those are called hyper-local media, and we use that for PACE and our satellite office with great success. Example locations, if you're not familiar, for those two campaigns were carnicerias, mom and pop style businesses, and those promotions might include door or floor decals, counter cards with tear sheets, large posters in some of those smaller venues. We also place radio ads in non-English threshold languages, which are recorded scripts and on-air mentions, interviews with on-air hosts, on-location promotion events. We do those at our PACE open house events. We also have reached out and done some digital ads, and those include geo-targeted ads on mobile devices in areas with high member concentration. So we kind of try to target our 5 top cities of membership. We also have done targeted display ads through vendors' shared networks on social media platforms. We retarget ads based on user search profiles, and you're probably all familiar with this, but if a user is receiving ads for prenatal care, that's because they've searched for pregnancy information and they know who you are and what you're looking for. So we've taken advantage of those opportunities as well, and also we use social media ads on Facebook. Our digital vendors, we've used 2 different vendors, and they have created a profile for our campaigns. And for example, a One Care Connect profile was low-income seniors living in Orange County, and then also caregivers 40 to 50 years old. That was the profile. And then ads were targeted to those demographic groups that made sense in that profile. So we then review the data and information supplied by vendors through their media kits and their rate sheets. We match the potential marketing vehicles to that target audience that we've established. Geographic distribution, for example, is one key area we look at, a community paper in Garden Grove for PACE. Member media preference, for example, outreach to seniors, as I mentioned before, might include resource directories, newspapers, magazines, and radio. Those are traditional unfortunately, their outlets. We maximize our impact of our campaigns using complementary marketing placement, and that has included on-air interviews and mentions with radio stations that we have relationships with, program coverage via articles. For example, we bought placement in Senior Reporter, and then they covered our PACE 5-year anniversary and published an article. So we leverage any opportunities like that for more exposure. We've also increased our radio airtime by purchasing when they offer to buy two, get one free. Those are other opportunities that we look upon to expand our coverage. We do, as far as once the decision has been made, we use our procurement policy to purchase identified marketing and educational opportunities within our budget approved by your board. And the expenses under $10,000, there's no bid required. For those that are between $10,000 and $50,000, we do informal bids or quotes that we obtain from vendors for a particular service. And then over $50,000, we go to formal bid or RFP, of course, as part of our due diligence. And we do that, of course, to ensure that we're looking at current businesses that are offering services because the industry changes. So we're constantly taking a look at that as well. So this is just a snapshot of our budget for the last 5 years, noting some justifications down below. For example, OneCare Connect direct mail expenses were not included in advertising GL 25 in fiscal year 18 and 19. That was because they were included in the member communications. That's why you'll see a variance there, GL 62. And also, the budget was increased for PACE as part of the expansion and aggressive enrollments in fiscal year 19. So hopefully some of you have seen our current educational campaign, the Quality Care campaign that has been out there. I'll show you. There's a few of the ads in the bus shelters and the billboards. So the purpose of this educational awareness campaign was to highlight CalOptima as California's top-rated Medi-Cal plan here in Orange County. We also wanted to encourage members to obtain services that contribute to higher HEDIS quality scores in those 5 areas that are in your presentation. We highlighted those 5 for this campaign, and also to increase general awareness about the importance of preventive health and wellness. This is an example of our current marketing campaign of our competitive program, OneCare Connect, and this is our current PACE advertising. And I also want to point out that we do leverage established communication vehicles to extend the campaign, the impact of the campaign with the same look and feel. And we do that in our collateral materials such as flyers and brochures. We highlight our new ads in our Community Connections newsletters, Provider Press, Provider Update, on our website, and through our social media platforms. So we would use Facebook, Instagram, and Twitter to showcase these ads. So we hope this clarifies our existing process, and I'm happy to answer any questions and obtain feedback from your board. Thank you.
So staff, Mr. Director Berger first, then Mr. DeLuigi.
Great. Thank you, Bridget. Very impressive stuff. Lots of good work. I have a few questions and perhaps some suggestions as well. I like your educational campaign, you know, the collateral materials that you have. Just a minor suggestion. I think it's very powerful what you have on the "Don't Let Labels Define You." I really like that a lot. And I'm thinking, if I'm David and if I have anxiety and I want to be able to have a call with a warm person, you know, especially like in this case where it could be like a suicide hotline or something, and there's no phone number on this. And I think that is very important because, you know, when we talk about mental health and access to care, people want to they're not going to navigate through a website. They want a warm voice that they can reach out to. So I think that's very important.
Thank you. We'll take that.
So, and also, we know like when you go to Starbucks or any marketing campaign, right? The minute you walk into a store, there's like 20 logos so that it reminds you that that's where it is and that's what it's all about. And I think because you're investing in a lot of good collateral materials, it would be nice to have the same kinds of impressions in different places. So if you use the same thing, like what they'd see in a poster or in a bus stop ad, that you use that also for social media. So you have repetition.
Right.
In that sense, I think that's very good. And this is just me, so please correct me if I'm wrong. I'm looking at the early screenings can save lives ad. And I really like it. Again, it's a call to action. Again, if we can put a phone number, that would be great. But a good portion of that sign is actually about the CalOptima as a top-rated Medi-Cal plan in California. And I'm not sure if what is the purpose of this billboard sign, right? I mean, I think we take pride that we are a number one, we're a top-rated medical plan. But if you're using real estate for a reach out to your community for awareness, I like that it should be there somewhere in this ad, but I don't think it should take as much real estate, because what you really want is a call to action and visibility. And I would like to see a little bit more of that, of what it means to the community and what are we trying to get out of this sign. Right. So
Thank you for your feedback.
that's 2 cents worth.
No, thank you very much. Mr. DeLuigi, you're next.
Thank you, Mr. Chairman. Bridget, just a question on the One Care Connect. I noticed that the budget on that over the last 3 years has dropped quite a bit. I think in the final year, it's about 200,000. I think started somewhere up around 400 something. Are you doing less advertising? I mean, I guess the one thing I think about is CalOptima's competitiveness in Medicare. And if I gauge by the volume of mail in the run-up to the Medicare enrollment, it's gigantic. I mean, you got all kinds of stuff going on. So are we putting adequate amount of resources there?
Well, I just wanted to point out that our direct mail expenses had been in there, and then they were not included in there. So you're seeing that move, those direct mail expenses, that our potential members were being reached out to, but it was coming out of another budget. It was coming out of our member communication budget as potential members. So there was still the outreach. But yeah, that's something that we certainly are working towards. We have a lot of strategies in place for One Care Connect. We haven't stopped, and we'll continue to look at new opportunities.
We're losing membership. A little bit, but we're losing it. But you don't feel that's in any way associated with the amount of money we're spending on
Right. I'll be going to budget, and I'm certainly going to ask for some more dollars, because I do think that would absolutely support and help our efforts with enrollment.
Thank you.
Supervisor Doe.
Yes, I agree with Director Berger that we usually don't want to mix more than one messages in any advertising thing that we do, coming from a person who advertises to save his career for a living every 4 years. We always just keep to one message per mailer or per effort. So in that, I agree, but let me touch on something that's probably a little bit beyond issue-specific advertising. When I go out and speak with my constituents, and I bring up the statistic that we cover 1 out of every 4 residents in the county, you can see jaw drop. Like, literally, like, what? People have heard, from time to time, CalOptima. And I tell you, even as a chief of staff on the board of supervisors, didn't really know what CalOptima does. We kind of know a little bit about it. It kind of exists on its own. And so a lot of what we do is built on credibility, right? Just like Kaiser, that brand, Cigna. People talk about health plans almost like by name to identify with a certain philosophy, a certain business model in healthcare. I think we should focus on building up our brand, the CalOptima. We need to get out there and let people know we are probably the biggest health plan in the county. And we also are the best health plan in the state 5 years running. I mean, these are things that we should just let people know right away. And then we should make that our first effort. Because I think once you build that credibility, a lot of things will flow from there. When, like the PACE program, any of the things, the outreach that we do, it has that credibility already because people know what we are. I asked Michael in my briefing, well, our members, how often do they hear the name CalOptima? And usually only like when they get the newsletters and once in a while, and then maybe if they're new, they get to sign up and pick their network. But outside of that, they really don't know much about CalOptima. They just know the network that they sign up for. So why not? Why not, establish our name more and better? And with that in mind, I also talked to some of the directors, and for an agency of our size, should we think about maybe even spending a little bit more on marketing? For all that we do and so many different populations that we try to reach, 620,000 a year? That's not very much, do you think about it, in terms of all the ways that we can reach out to people? Social media, right, print, TV, but whatever, billboards. $620,000, that's barely a county supervisor campaign, for 3 months cost. Here we have an agency for a year. So just something to think about. And I think it would be beneficial for all of us to think about in our community, what can we do to promote our name even more, how to be even more effective in the future. Thank you.
I think your comments are very well taken because, you're right. We do care for 1 out of every, actually I think it's more like 3 3/4 patients in Orange County. And a lot of people really seriously do not know what we do. However, we do have some restrictions as well, and that we're not really allowed to sort of promote Medi-Cal. Is that correct? Or can you go through how is it possible to kind of do both, to educate the public as to what we do and not fall afoul of what the requirements are within the law?
Right. We work closely with our regulatory affairs and compliance department because there are a lot of nuances where you're walking the line a little bit. And so we check in to make sure that we are adhering to the latest guidance and policies. But yes, we can inform and say some of these things that Supervisor Doe has suggested. But anytime we talk benefits or anything like that, that is considered marketing. So we work very closely with our RAC team to ensure that we're meeting compliance.
Other comments of staff? Go ahead, Mr. Sanchez, go ahead, please.
Many of the messaging that I saw in there was very similar to what other large healthcare agencies do. So you might want to just maybe either leverage each other's efforts because we have similar messages sometimes. We may be saying the same thing, which is not a bad thing, but maybe we need to say things that are unique to us. Because we do have health education as part of the healthcare agency, and we do a lot of advertising as well. So just something to consider.
That's a great suggestion. Other comments? Dr. Katibi, please.
Thanks, Brenda. A couple questions is, I love the educational piece. I think it's incredible. It's beneficial to the community members. I think one area I would want, as a board, if that's possible, to shy away from, that really kind of, I think, gets many people in the community a little bit more uneasy is there's certain advertisements in other counties, in Northern County, east from here, south from here, where these billboards advertise like it's nothing. They write $0 health plan, hashtag best deal. And I will tell you, as stewards of taxpayers, I will tell you, I love the fact that we're providing access to members, because at the end of the day, that's what we want to do, right? We want to provide access to the most fortunate and vulnerable members of our community. At the same time, we got to be mindful that I hope to God this is a bridge program, right? Medi-Cal is a bridge so that you can get thriving, growing, and living. Yes, we have a certain sect of the population who are disabled, and we need to make sure we care for those members, and I want to make sure we continue to advertise and cater to those individuals. At the same time, we got to be mindful. We live in a county where I think we're the only Medicaid program in the county, right? Is that correct? Whereas I work even in Northern California where we have offices, we work in counties where we have multiple health plans. So then you have to focus on competing for these Medicaid members, right? But here, we're not really competing with anybody. You get below that FPL, that federal poverty line, there's only one plan you're going to go to. It's CalOptima. So I just want to make sure as a taxpayer, when I wear my taxpayer hat as well, I want to make sure that, hey, listen, are we spending hundreds of thousands of dollars to make our Medicaid member feel more comfortable about the fact that they're on Medicaid? Or are we spending money on marketing to educate them on public health? I don't see why not on the public health side. But to make them feel better about being on Medicaid or going out there to attract more people to join Medicaid, I think that's where I have a concern. And that could be a philosophical concern or more of a CalOptima concern. Do I want to spend taxpayer-generated money on marketing more or towards actually helping them, get healthy, get back in working, get back in their quality of life? And that's where I want to see our money being set. So I would hesitate on increasing budgets unless it goes towards more of the One Care Connect, where it's Medicare. And Medicare, it's a source of income, I think, for our organization, which is fine for me. But to spend income towards Medicaid advertising to get more people on our Medicaid program, I would hesitate drastically on that. And then two, I would be very uneasy if we started advertising more of like 1 in 4 is on Medicaid, or $0 health plan like I see in some parts of Northern California, or hashtag best deal in the county and other places. Or one place had $0 drugs, $0 co-pays, hashtag, again, best deal. And it just drove many people nuts in that community. So.
You see any of that stuff in Orange County? Have you seen any of that?
No, which is great. So I see our public health things, which I love. But to see, if I had to see them in this county, I think I would go in a public forum or some sort. Yeah, I can't see that doing that. Again, we're the only county health plan, Medicaid plan, so you know where to go if you are at that level.
All right, Mr. Schrader.
So I would just add, you're correct. We're a COS plan, so there is no competition. So we're not allowed to spend Medi-Cal dollars on marketing. We can spend Medi-Cal dollars on outreach to get members in for services, to improve the quality of care that we deliver to members. And so that's what you see. And that's why we try to sort of mix the messages, because we're promoting services, but we're also letting them know who CalOptima is, I think, which is part of getting them in for those services. So, and I think what you see in other counties is it's a two-plan model. So they are competing. So they're allowed to spend Medi-Cal dollars on some marketing. And so in those other counties, you're seeing, that's what you're seeing. Right. Yes.
Other comments? Director Schofel.
Just briefly, thank you. You're right. We have a captive population here in Orange County for Medicaid members, and it's quite large. So I see the Medi-Cal educational line really not as a marketing line because we don't need to market to Medi-Cal beneficiaries. We need to serve them better, more efficiently, things like that. And I think most folks in the industry would agree today as the compensation arrangements start becoming more risk-based, and I think we're looking at a lot more of that in the future. Wellness is becoming one of the principal strategies to look at. To tell you the truth, educational outreach in terms of reaching that population, which isn't the easiest population to get the message across to, especially for a lot of the more serious chronic diseases. That when I look at these numbers, I think that they could go up, and I think that it wouldn't be to promote the ideal lifestyle of being a Medicaid beneficiary in Orange County, but rather how to stay healthy, how to stay at the most basic level. Those are the messages that I would craft, and I don't see that as a marketing ploy necessarily. And maybe that's your sort of titration when you get to deciding how to put that message out there. But the more we could outreach in terms of meaningful educational messages, I think our wellness strategy would be very well served, and we would be on our way to a truly modern and forward-thinking coordinated care model. So thanks very much.
Thank you.
Thank you. Other comments?
Mr. Chair, on Scott's point, I think, Bridget, it'd be a great idea to take what Richard has said and Scott has said and really see what the county public health office is doing, right? They have a public health officer. They have, how many public health officers you guys? You guys have like a good number of public health officers who are, in the community and doing things. And I'm sure the county has a huge budget because for them, maternal mortality rate, opioid overdoses, these are big things, just like for us as well. If we can combine our messaging or share advertising space, I think it'd be a good stewardship of taxpayer funds.
One more comment, Supervisor Dell.
Mr. Chair, I think it's important to be clear in what we're talking about. It's not marketing to promote just CalOptima, or as Director Schofel said, not to promote the Medicaid lifestyle. There is no such lifestyle to promote. We have to recognize that the work that we do and how credible we are in getting the message across, whether it be healthier lifestyle or to offer the services that we provide, is no different from any of the other initiatives that we have taken on in the county. And how did they get started in the beginning? They established the standing by having a recognizable name with a respected platform. And I'm looking at Director Berger, like Healthy Smile. The name has to conjure up a certain service, right? A level of service that people probably up until then did not recognize, did not know that exists. And so that's what I'm talking about is when we establish more of our standing within the residents of Orange County, when we speak up and we talk about a healthier lifestyle, childhood obesity, annual checkups and things like that, it affects everyone. It imparts that information to more than just CalOptima members. And that's all I'm saying is that what we can do to gain that credibility, that standing, is all I'm focusing on. And if due to the limitation with the use of our funds, and we need to mix messages in order to establish that, so be it. Now I get it. I see why you do it. But I think we need to go to the very fundamental, the very first thing, which is people don't really know what CalOptima does. And I think the statistic that you mentioned, Mr. Chair, about in addition to ensuring 1 out of 4 patients, like the majority, right, of the patients that the hospitals treat actually are CalOptima members, right, or at least in the emergency room and things like that. If those statistics can go a long way in letting people know that the work we do is really important, and that despite the overwhelming responsibility, we are the #1 plan in the state 5 years running. Just something to think about. And I understand that I'm certainly not advocating for people to go to the $0 medical cost. And no, we don't want to encourage abuse.
Thank you. A very interesting topic. On to another interesting topic, homeless health. Cheryl? And thank the board. Thank you, everybody, for your thoughtful comments and discussion, a very interesting discussion.
Good Good afternoon, Chair Yost and members of the board. I'm Cheryl Maronk, Director of Strategic Development, and I will be providing an overview of our initiative to address and optimize care for our members who are homeless this afternoon. So as you may know, there are approximately 4,800 homeless individuals in Orange County, and last year more than 700 were relocated from the Santa Ana riverbed. CalOptima has been working with the county and other organizations to provide services to our members who are homeless, yet last year more than 250 homeless individuals died on the streets of Orange County, and it's estimated that nearly half of those were CalOptima members. For members who were relocated from the riverbed, CalOptima conducted screenings and coordinated care for those in need. And the county also provides services to our members who are homeless, such as through the Comprehensive Health Assessment Team for Homeless, otherwise known as the CHAT-H Public Health Nurses. Also, the Behavioral Health Services Outreach and Engagement Team, otherwise known as the Blue Shirts, provide behavioral health services for our members. These services connect members to medical homes and to behavioral health services as needed, but please note that they do not provide medical treatment services. Through these efforts and through our member health needs assessment, we know that our members who are homeless face some significant challenges to receiving care. Our efforts in serving our members who are homeless include things like participation in the county's whole person care pilot. Through this pilot, CalOptima has several personal care coordinators, or otherwise known as PCCs. CalOptima also collaborates with the county and other participants in the pilot to share data across the board for our members. And then we also participate in meetings and various projects that are coordinated across all of the participants in the whole person care pilot. CalOptima also committed $11 million for recuperative care services for CalOptima members under the whole person care pilot. And as you'll recall from your December board meeting, your board recently committed $11.4 million for services for CalOptima members at the new Be Well Regional Wellness Hub. And while these efforts are yielding some good outcomes, there are still some gaps to be addressed, specifically in the medical needs of our members who are homeless. Currently, our members are assigned to primary care providers and health networks and are eligible to receive all medically necessary Medi-Cal benefits. Some of our members who are homeless are located in various places, such as the courtyard, shelters, parks, or other public spaces, and these members receive public health services in a number of ways. As I mentioned, through County Behavioral Health Services Outreach and Engagement Team, who provide education and support to link individuals to behavioral health programs. Through the county CHAT-H public health nurses who provide targeted assessment, case management, health education, and linkage to medical care. Although, as I mentioned, these nurses do not provide hands-on nursing care such as wound dressing or injections and the like, as they're not a licensed home health agency. And our members also receive social services such as housing services, assistance with Medi-Cal enrollment through community-based organizations and the Social Services Agency. Despite all those efforts, our members who are homeless do have many challenges in receiving care because these members are frequently on the move and they don't have stable housing, which results in difficulties in them making and keeping scheduled appointments with their providers. They often have difficulty being able to communicate effectively and efficiently with their providers. And as Michael mentioned earlier, many of them have issues with transportation because there is no set location to pick them up at, or they are not going to be located in any one place long enough to schedule a ride 48 hours in advance. So we have some opportunities to enhance service coordination for our members who are homeless, and we can do that a few ways. One is to leverage the new Whole Person Care Connect system that was recently completed under the Whole Person Care Pilot. And this is a system that allows for data exchange between the county, CalOptima, and other service providers under the Whole Person Care Pilot. And that will let us know of emergency department or hospital admits for those members who are homeless. It also lets us know when those members have entered into a recuperative care service provider. And it also tells us when those members have received other whole person care pilot services. We're also increasing our engagement with other service partners, such as through attending whole person care pilot hospital subcommittee meetings, where we engage with the homeless navigators that are working in the hospitals, case management meetings, and other collaborative meetings related to healthcare services for our members who are homeless. We also are looking at broadening the role of our personal care coordinators. We do have personal care coordinators who are dedicated to our members who are homeless, as I mentioned, and we're looking at increasing the presence of those PCCs at the courtyard as well as at other shelters. Additionally, we have an opportunity to look at some other innovative ways to address the medical needs of our members. One of those ways, as Michael mentioned, was developing a clinical field outreach team that would provide medical services to our members in the field, members who are homeless, and this is in support of our current delivery system. So this would be a more mobile team that would be able to go out to where the members are located in places like the shelters or in parks or other places where members who are homeless are congregating. They would be flexible enough to offer same-day service as well as after-hours services and on weekends, so that those shelters who don't necessarily have clinical services at them or don't have a mobile medical unit that's available for the shelter could have services available for people living there. We would be partnering with the county's Chat-H team as well as the behavioral health outreach and engagement teams, because those are the folks that our members who are homeless know and already are working with. So we would anticipate receiving referrals from both of those teams. As I mentioned, we would want to provide after hours and weekend coverage, and we'd want to engage with a provider or vendor who is already doing this kind of work. So there are a number of providers such as FQHCs who have mobile clinics that go out to the shelters already, and they're very engaged with our members who are homeless and know how to work with these populations. It's also important to note that
Carol, tell me about the after hours and weekend coverage. Sorry to interrupt you. What did you mean by that?
So oftentimes the shelters are working already with FQHCs who provide mobile services. So several of them have mobile clinics that will go out to a shelter maybe once a week or so and provide services for a few hours at a time. But outside of that, it's very difficult for them to connect medical services to individuals staying at those shelters. So we would want to be flexible enough to be on call to go out to those shelters. And right now, those services don't operate beyond daytime hours of 8 to 5. So we would want to make these services available after 5 p.m. and on weekends when it's difficult to access other services. It's also important to note that CalOptima's funding can only provide services for CalOptima members, and therefore it'll be important for us to contract with an organization that can provide services to homeless individuals who are not CalOptima members and who have access to other funding sources to do so. And entities that I mentioned, such as FQHCs, Federally Qualified Health Centers, are a good example of this, as they have federal grants that they receive to provide care for the community's most vulnerable, including uninsured and underinsured individuals who may be homeless. So our next steps are to conduct an evaluation of feasibility and permissibility of the various options that we're looking at to develop these teams. And we will conduct vetting and seek input from our stakeholders, for example, our FQHC partners, our health networks, and we will be returning to the board with the options that we develop and some specific recommendations for putting these teams out there.
Questions of Cheryl? Mr. Penrose.
Thank you. Great report, comprehensive, an issue that comes up almost every meeting. I guess I would really underscore the last point that you made about going out to all of our stakeholder groups and getting input. The only concern that I would have under the options under evaluation would be continuity of care. I think I know there are multiple solutions at work across the county, and probably are disjointed, or there are various types of solutions that are happening and could use some coordination of care. But also, if we, with all good intentions, try to implement something, we may be more disruptive without intending to be.
Sure.
And so I'd be concerned about that. And pulling the stakeholder groups together is a good antidote for that. So I appreciate that point.
Other comments?
Just a
Dr.
quick
Kadibi,
question, Mr. Chair. Cheryl, tell me about patient care coordinators and how they work and like ratios and all that stuff. Is it one PCC per member? Is it one PCC per a certain area?
I'm not exactly sure of the ratios, but we can get that information, and Tracy may know that. But the PCCs are non-clinical staff members who work to connect our members to their PCP. They will work with the case manager to ensure that the member is receiving the services that they need, help the member to connect to a case manager so that a care plan can be developed. So essentially, they're providing navigational services that are not clinical.
My next question is, I'd love to get some more information, maybe privately, about the clinical field teams, in part because, I spent 6 months of my part of my residency just volunteering on the side. And one of the places I volunteered was here in the county doing the mobile clinic on every 2 Saturdays a month. And I can't remember in the sense, I can remember everything, but I won't tell you exactly what I remember. But I remember when I was in that mobile unit, I would say for that 6-hour shift, I'd see 4 patients. And so it drove me nuts. And I said to myself, wow, there's a full-time physician here, ready to do whatever you need. I can only see 4 patients. And I would tell the facility, hey, listen, why don't we go to a different area? No, we always have to go to the same area every time. It's because that's how the community knows where we're at. And so I question some of these. I think these mobile units are fantastic. I think they're great. They go out in the community, they help. But I think they need some structure. And I think when it comes to addressing the homeless health, physical health, as you say, I think we need to emphasize structure here. For me, I would want to learn a little bit more about this project, in part because structure for me entails, let's train, educate everybody that you need physical health care. Go to these shelters. There'll be mobile vans there for you, and we can increase those after-hour times with you. I don't mind. Go there for structure. There's certain facilities that have areas where they can get access. I would want to learn more about why that's not enough. Instead, we have to go out to parks and certain areas where people live on the streets or to provide this care. Because at that point, then it defeats the purpose of structure, which is get them to the shelters, get them access, and then hopefully get them to transitional housing through maybe the Be Well initiative or something like that. The Be Well initiative, what Supervisor Doe is saying, is a great example of structure. There's a crisis stabilization center. There needs to be. There's PCCs that'll coordinate your care to get you into some permanent housing potentially. But if we just focus on diminishing that structure and just now go into parks and wherever we want, I don't know what to say, but going out in the areas, that defeats the purpose of structure and helping these individuals get structure in their lives. So I would just emphasize, I would love to learn more about clinical field teams. I don't think I'm ready to wrap my head around that quite yet, but I think maybe with little discussions, I would like to maybe potentially think about that a little bit more.
Sure.
And then with those mobile units, I think we need to do a better job of identifying where they go to and be more efficient and flexibility. Again, I spent 6 months in Huntington Beach doing this, and it drove me nuts. Not only that, I'm not helping, I'm touching maybe 4 lives a day, and they weren't even homeless individuals. They were maybe just undocumented individuals who knew about the area. So thank you so much.
I mean,
Okay, Mr. DeLuigi, go ahead, you're next.
To Dr. Katibi, I mean, the thing that I'm thinking is that, quite frankly, this population defies structure. They defy structure.
Right.
Not intentionally, but it's just a pretty tough lift. As I hear it, we're looking and exploring whether or not we want to augment the, bringing the care to the shelter. So we start out with the shelter because they're there. But the reality though is, I mean, we're gonna have to work with this as we move forward. But the reality is, we want to get to a point where we've got permanent supportive housing. Then maybe efforts to teach those folks who are in permanent supportive housing where they might access, dependable care. It's going to be at this location, et cetera. But, well, I'll tell you, I look at this stuff and I see a very, very difficult challenge. And it's going to defy some of the kind of the conventional wisdom that we might otherwise bring to some of the healthcare challenges or medical challenges we talk about. This is going to be tough, I think, going forward.
Other comments? Director Nguyen, go ahead.
So I think, I think number one, I think it's really important to do both. And it's important to do both because having a structure that people know where to go is one thing. And then there are folks that are suffering from various different medical ailments that, like you were saying, defy structure and that we got to reach out to. So it makes for a tough thing, and it got me thinking a little bit, and I think the biggest thing, another way we can outreach is a lot of the emergency rooms. We talk about the emergency rooms. We talk about folks on holds and being boarded and things like that. If we can really network with various emergency rooms to then somehow give a link or a call to one of these mobile response teams if we know that they're homeless, I think that's another way that we can have a catchment in addition to the shelters and the places. And I think I hear at Econ, I think I've been a part of projects where you're just like twiddling your thumbs. And I think a lot of that has to be, we have to really focus on areas where we see the most members. And I think that's a lot of due diligence prior. It's going to take a lot of work, but I think certainly we have to do both, because if we do only one, there is structure already. It's just a lot of these folks are kind of being lost in the wayside. And I think we need to be able to outreach them too. So.
Supervisor Doe.
Thank you. Some of this we will discuss in closed session, but to answer some of your questions directly, because it'd be beneficial for the public to know this. To answer first your question about the lack of structure for homelessness versus structure for mental health. A lot of time mental health, once they get to a crisis, that's an involuntary process by definition. And most of that care is longer holds in the residential treatment capacity. That's why structure fits in that with that issue. When we're talking about the homeless, it's really difficult to ask the homeless to leave wherever they're at to go to a clinic, whether it's a mobile clinic or a fixed clinic, because they have to leave their personal belongings behind. They can't move all those things in order to get help. And also the logistical nightmare of having to move all that stuff in order to get help, which prevents them from getting the help. But those challenges are there and they exist, whether the homeless person is in Orange County or San Diego County. But we have to ask ourselves why our deaths, two counties very similar, we're within a few thousand people into population apart. And yet their number of deaths is less than half of ours. Less than half. And so it's an issue that we need to get to because Cheryl mentioned earlier, you said half of the deaths were CalOptima members. So beyond delivering of care, we have a moral obligation to look into this. Director Nguyen, we do have when the homeless goes into the emergency room, we have the whole person care program that then makes sure that when they exit the emergency room that they have follow-up services. So we do have a program. And the county just a couple of months ago directed funding for data integration, which means all of the hospitals maintain a database and they share that information. So that way a homeless person can go to any provider, hospitals or doctors, and that information is known immediately, uploaded and it's shared immediately. So that way there's no duplication of care. So this is really, we are talking about a system of care that the County of Orange, together with many stakeholders and CalOptima, have been putting together. And there's so many pieces that one day, perhaps, we will have staff and with, of course, I can contribute as well, to do for this board a system of care, like as the Director DeLuigi mentioned earlier, anything from emergency shelter to bridge housing with wraparound services to permanent supportive housing and all of the things in between. So if we think of the system of care as like a freeway, there are many ways people get on that freeway, right? On-ramps, homelessness, mental health, drug addiction, abusive family situations, many reasons. Well, once they get onto that system of care, how do we get them out? What are the off-ramps? And that's what we're talking about. And I think at some point with a very comprehensive presentation as to all of these things that we do at CalOptima, as well as things that may impact what we do as well for serving the same population, it would be very beneficial.
Other comments?
I'm going to stick with my points again one more time about efficiency and accountability. Even with mobile units, the money's there. We're pouring money to help the homeless in terms of addressing their physical health. I'd love to support a plan that is comprehensive, that holds these programs accountable. Partnership with the FQHCs are great. If we're going to fund them, let's make sure they're held accountable. For those 6 months, I was seeing 4 patients a day. I wish somebody would come tell my boss, hey, listen, we're spending tons of money on this, and Hoag's involved, and this is involved, that's involved. So why is that money being spent this way? So whatever we decide to move forward with, there has to be a certain degree of accountability. I want to help the homeless. I want to help them get structure in their lives. I see homeless patients in my clinics throughout the state all the time, and I can see why it's challenging. I'm okay with it. They bring their bags of things. They're not always the most hygienic individuals. We work around their schedules. We try our best, and there are certain people who can leave that. We have to have the county provide locker rooms for these guys to hold their stuff so they can go see the doctors. I mean, what's next? So there has to be some degree of accountability. Thank you so much.
Okay, thank you.
Thank you.
On to the strategic plan, Mr. Schrader.
Okay, so included in your board packet is a progress report for the second year, 2018, of our 3-year strategic plan, 2017-19. So a lot was accomplished during the second year, and it's all summarized in the report in your board packet. But I'm just going to highlight some of the areas that we covered in 2018. And so our CalOptima mission is to provide members with access to quality health care delivered in a cost-effective and compassionate manner. The 2017-19 strategic plan that was approved by your board gives staff direction and is a guide to implement that mission. And your board established 3 strategic priorities: innovative programs and services that integrate care and expand access for our members; value, including both the quality of care that our members receive and cost effectiveness; and partnerships and engagement with our county, with providers, community stakeholders that improve the coordination of care and lead to better member outcomes. And then the two building blocks on the bottom were workforce performance, to have an engaged and dedicated workforce that is responsive to our members and to our provider partners, and then financial strength to ensure adequate reserves, and that nearly every dollar we receive goes to paying providers to create access and to deliver quality care to our members. So this is these are the pillars of the strategic plan. Starting with the first, some of the innovative ways that we've integrated care and expanded access for members in 2018 included PACE expansion. So we want to create options for frail seniors and their families in front of or in place of expensive long-term care, for better member satisfaction, quality of care, and lower cost. And our efforts included onboarding 4 satellite sites or CBAS centers through the alternative care setting model, and I think a 5th is about to come online in February. And we implemented a process that we talked about at the top of the meeting to consider request for letters of support from organizations seeking to offer PACE services in Orange County independent of CalOptima. Whole child model is another opportunity to integrate care for our community's children who have complex health care conditions. Today, the system, as you know, is bifurcated. The county is responsible for services related to the child's CCS condition. CalOptima is responsible for services not related to the child's CCS condition. So for parents, that means dealing with 2 different agencies. It can get pretty complicated, and as well as for providers. So the improvements will result in a consolidated system at CalOptima, where CalOptima is responsible for the majority of services for children in the CCS program effective on July 1. And then Denti-Cal is a Medi-Cal benefit that CalOptima does not cover today. It's carved out to the state Denti-Cal program. And so our efforts include engaging local stakeholders and conducting analysis to explore if carving in the benefit would increase access, improve quality, and prove financially viable. There is one other county in Northern California that has carved it in, and they're looking at 2 years of losses before they project they're going to get to financial viability. So we all know if Medi-Cal rates are lower, Denti-Cal rates are even lower. So it's a tough program. It's a tough program, and there are reasons that the access issues that exist are there today. And so we need to understand if CalOptima is going to assume this program, we would only do it if we felt like, given those rates, we can make improvements for our Medi-Cal members. On value, another of your board's strategic priorities, again, is value, or the combination of the quality of care and cost effectiveness. For the last 5 years in a row, NCQA has rated CalOptima the top health plan in California for both commercial and public plans for our Medi-Cal program based on the quality of care that our members receive. Likewise, for the 4th year in a row, the department, DHCS, recognized CalOptima as the #1 large Medi-Cal managed care plan also for the quality of care that our members receive. And these awards, of course, confirm the value of our public-private partnership, and we're grateful to the provider community for the cost-effective, high-quality care that they deliver to our CalOptima members. And then I just say the capitation rates we pay to health networks were rebased in 2018. That goes towards value. We wanted to ensure alignment between the funding we provide to health networks and the services that go to our members. The medical loss ratio audit of our health networks, again, that was to ensure that the dollars that we pay out to health networks are that the majority of those dollars are going to providers to pay for care instead of for administrative purposes. And then the delivery system evaluation, which we talked about today, is getting kicked off to take an independent look at the efficacy of our current model and if there are possible improvements. The final pillar of your strategic plan was partnerships and engagement. Better together with our community partners, we more fully serve CalOptima's members. For homeless health, of course, your board has made 2 commitments for a total of $11 million for recuperative care through the Whole Person Care Program. For the Regional Wellness Campus, your board made an $11.4 million commitment in partnership with the county, Kaiser, and Providence St. Joseph Health to create a coordinated system of mental health and other supports for all Orange County residents. The Member Health Needs Assessment was published in 2018. It was based on surveys, focus groups, and communities, and interviews of more than 6,000 of our members and also of providers and community stakeholders. And the assessment gives us insights into the challenges that our members face that can impact their health. And we continue to learn from that in our community. More and more is using that report. So I know the county is using it. A lot of stakeholders are taking advantage of the investment that your board made in that Member Health Needs Assessment. So it's going a long ways, I think, in Orange County. And then related to community engagement, we launched a family advisory committee for the whole child model. I think tonight was the first time your board heard from the chair of that committee, Bo. And that committee, of course, is largely made up of parents of children in the CCS program. So I think we're going to get a lot of good input from that group of parents. In addition, CalOptima is very much in the community. We continued this past year our regular meetings with the Hospital Association of Southern California, with the Coalition of Community Clinics, the Health Network CEO meetings, the Health Network Joint Operations meetings, and we host, and I'm not sure your board's aware of, we host a Community Alliances Forum. It's at the Delhi Center, and it consists of almost all the community-based organizations in Orange County. And CalOptima brings all of those organizations together once a quarter, and because those organizations provide services to our members. They may be outside of the medical model, but we're all taking care of the same individuals. And so we bring those folks together, and it's a very collaborative group. So I invite you to make your way out and to attend at least one of those meetings. They're really productive. So the 2 building blocks, workforce performance and financial strength. So under workforce performance, again, we want to make sure CalOptima's workforce is engaged, mission-driven, and responsive to our members and to our provider partners. We have sound operations as reflected by the near-perfect scores in 2018 of number 1, our accreditation renewal by the National Committee for Quality Assurance. A number of auditors from NCQA came on site, and our annual audit by the Department of Healthcare Services. As big as we are, we had 1 finding, and I characterize it as a minor finding. I mean, that's just, plans our size, I can tell you, you can look at their reports, they're getting 20-plus findings. And I think it's a reflection of the work that our audit and oversight team does with the continuous monitoring of our delegated entities, health networks, our PBM, our behavioral health vendor. They're continuously issuing findings, and our health networks are responding with corrective action plans, and they're addressing the issues. And I think what that results in is we're finding the issues, we're stopping them before they escalate into bigger systematic issues. And so when the regulatory folks come on site, they're finding a pretty clean shop. Okay, and that's a lot of work considering it's not just CalOptima, but it's 13 other organizations. So credit to our compliance department and the audit and oversight group. We also promote team building through the quarterly all-hands meetings. In this room, we have to have 2 sessions to get all of our employees in. And then our Employee Activity Committee is really active, and they sponsor probably the funnest events at CalOptima, which would include the Halloween costume, a talent show, walk across America with the executives, the holiday luncheon, and other sorts of events like that, as well as a lot of fundraisers. And this is the group that that launched the scholarship contest for our CalOptima members. And it's through their fundraising that, that those scholarships were possible. So last, I'd just go to financial strength. CalOptima is in really strong financial shape. We, in 2018, received a clean financial audit from the outside auditors for the 2017-18 fiscal year without any need for any material adjustments. We maintained one of the leanest administrative loss ratios or overheads of any health plan in the state of California for the Medi-Cal program. We maintained a high medical loss ratio. Again, more than 95% of our funding is going out to providers to deliver quality care to our members. And then, and I think it's funny because I'll hear from other plans about your MLR is really high. Doesn't that concern you? No, that's what we want at CalOptima. We want the funding to go to providers. I think other health plans see MLR as that should be around, maybe 85%. We feel like, no, we want 95% of every dollar to go to providers. And then last, CalOptima's financial reserves. I think your board has been clear about we want adequate financial reserves so that when, not if, but when there are those delays in funding from the state, that we're able to pay providers for the services that they continue to provide to our members. Because providers don't stop continuing service just because there's a financial issue in Sacramento, so we don't want to stop paying them likewise. So that's just a quick summary of our 2018 accomplishments. I just want to thank your board for providing leadership and direction every month and through this strategic plan. And in 2019, staff look forward to continue to advance, again, innovative programs and services, value, and partnerships and engagement. So that completes my report looking back.
Mr. Chairman,
Yes.
I have just a question here regarding PACE expansion because CalOptima has two roles here. One, that we are expanding PACE program because try to serve more seniors. But second, we have to approve, we have to review criteria and actually recommending private sectors to open up the PACE program. So we have to compete against, what we are thinking that when we hear that PACE expansion here, that means that we are competing. How are you going to balance this, that between that CalOptima is expanding it, at the same time we are actually recommending private sectors out there. For me, government has to be a facilitator instead of competing against private sector. So how are you going to balance this?
Sure. So the way I view it is we have a PACE center. That decision was made. And since we own and operate a PACE center, we want to make sure that it's run efficiently and maximize the value of that PACE center. And one of the ways you do that is by maximizing enrollment in that PACE center. We don't have any plans for CalOptima to open any additional PACE centers. If there are additional PACE centers in Orange County, that'll be the private sector. I think this has been the clear direction from your board. But at the same time, the direction's been staff make sure that our existing PACE center is financially viable and well run. And I think that's the focus, is we just want to make sure that the average daily attendance, that we take maximize the potential of our PACE center. And we feel like by using satellite sites, we can get to somewhere around 600 members before we reach capacity for that center. And so that's what we're working towards. But we also, expansion, it's also creating options for seniors. For a lot of the seniors in our PACE center, it's because PACE is basically the combination of an adult day health care with a primary care clinic. But most PACE participants don't need to be seen in the clinic every day. So what we're doing is giving them the option that if you want to go to your neighborhood CBAS instead on most days, so you don't have to be in the van for a half hour, 45 minutes, maybe your CBAS center is only 5 minutes away, and maybe at your CBAS Center, I think the cultural and linguistics part is really important for this population. They're not interested in, at a certain age, in learning about, they just want to be comfortable. And so if going to your neighborhood CBAS is a more comfortable environment for you, we want to support that.
So it seems like 2 applied so far, and then how many more anticipation that you are expecting for this year or next year or so for PACE program, PACE Center?
How many satellite sites?
Not just the satellite sites, but private sectors that they just applied.
So through the, we had the window open for 3 months. It closed at the end of January. And so your board set guidelines for how we would evaluate those requests for letters of support. And the request came from 2 different PACE organizations. And I haven't looked at the results myself, but one organization could be proposing multiple centers. So, so I don't know that I don't know that it would just be one PACE center per organization. It could be one might say, I want to open one in Santa Ana and another in Irvine, and you know.
So is the state still going after the zip code that, you know, south and the locations?
So that was separate in terms of the coverage area for CalOptima's PACE license. And so our PACE license covered Central and North Orange County, basically sort of from Irvine north. And so we were approved for South County. So our PACE license now covers all of Orange County. And the private sector, what we're doing with the letters of support is we're saying you can open and operate PACE centers within CalOptima's region. So.
Other questions? Go ahead, Lee.
Just to jump in on that, you know, I love this topic, and thank you, Supervisor Steele, for the question. And I just would emphasize the part of if we end up writing a letter of support for those PACE centers, that is a question, at least in my mind, and the issue that Supervisor Steele is bringing up is an important one. We definitely want to provide quality access to care for all of our members. We also don't want to create a situation where we're being detrimental to our own PACE center and find ourselves in a situation where we may not be able to sustain what we're providing today.
Okay, thank you for that. And correct, and we are planning to bring back the results in April. And so that's when your board would potentially make that decision.
Other comments? Okay, 22B, going forward. I mean, there was ends in 2019.
So I think if, I know Supervisor Doe, for the future strategic plan, the next 3-year strategic plan, was there anything you wanted to add in that regard, or should I?
This
I'll
board,
launch into the process then.
I mean,
I'm sorry.
This board is.
So we're
yeah,
talking. So next up here is we need to start the planning process for our next 3-year strategic plan. And so what I would, and we want to involve your board in that process, and we really want to start with your board. So we're in the last year of our current 3-year strategic plan. It expires December 31st of this year. So it's time to begin that planning process for the new 3-year strategic plan. What we're proposing is to onboard a consultant, and the consultant would help with the planning, the facilitation of sessions, and the development of materials. And so what we would do, we would start the planning process with your board in the April to June timeframe. And the consultant would survey your board and then facilitate a strategic planning session, a full-day strategic planning session. And the strategic planning session that we're proposing, that I'm proposing, would be a half day or more of outside speakers from the federal, state, and local level. And then in the afternoon, there would be a discussion about your board's ideas for vision. Where do you want to take CalOptima in the next 3 years? And then following that strategic planning session that day, so we start the process with your board, and that strategic planning session could take place on a Friday or a Saturday. The next step would be between July and September, staff would take what we learned from that strategic planning session and the survey, and we would take it to your board's member and advisory committees and get their reaction, get their input, and then staff and the consultant would develop a draft of the strategic plan. And then we would come back to your board we would target October, that we would bring a draft of the strategic plan to your board in October, get your feedback, and then between October and December, make whatever changes are necessary, and then come back in December for approval. So that would be our sort of one-year process to develop a new strategic plan that would take us from 2020 to 2022. Yeah. Okay, thank you. The next steps then.
So Michael, Mr. Chairman.
Ron,
So you're envisioning the consultant would come on board before there's any sessions with the board to begin talking about some of the things that are on our minds?
We'd bring a consultant on board. We'd bring a consultant on board first to really help us prepare for that survey of your board members and for the strategic planning session. Right. So we would, so the consultant would help with gathering materials, creating an agenda, developing the survey, that sort of thing.
I think that's good. The one thing that occurs to me though, as we launch into the next 3-year increment is, and CalOptima is not unlike most other organizations I've experienced or been with. There's a tendency to simply add to the existing inventory of projects and activities and so on. And that's understandable, but I think, and again, we've been together a short period of time, but that's my perspective, as I've seen, we've added to it. But most of the other organizations that I've been with understand that they understand when they're not looking at managing that. What makes sense? What's a viable content of a strategic effort going forward that is doable? Nothing wrong with stretching, but let's not just continue to add and not take some time maybe to go back through the existing inventory and see if there's some things that maybe can be called out and maybe we don't move forward with. It's tough choices, but those are the kind of things that we probably should think of early on.
And I think what your board has been very good about on the last strategic plan is it's not a list of projects. It's a vision. So it's something like Supervisor Doe shared. Our vision might be a system of care. Okay, we don't need to define all the nitty-gritty projects that would go under that, but what do we mean when we think of where we want to be 3 years down the road in terms of system of care? What does that look like? That might be one of the strategic elements of your board's new plan. Another might be integration. There's a lot still carved out. There's a lot of different organizations taking care of the same members. Maybe it does or doesn't work for our members. Is integration, is that one of the strategic pillars? Maybe it is, maybe it isn't. maybe it's, quality of care that, so I think your board has been really good about those pillars rather than here's a list of projects that we didn't get done last time and we're going to, if I'm understanding you, yeah.
It doesn't matter how we frame it.
Yeah.
The reality is, what I said is true of all organizations.
Yeah.
We tend to pile on top of things in the past. So if we as an organization, strive to be effective in what we're doing and do the most important things, in all likelihood, we're no different than other organizations. We're going to need to maybe think about prioritizing too. All I'm saying is that some thought ought to be given to that early on, in a general sense.
Yeah.
So I think it's not how we're, I get the distinction you're talking about, but the issue is still there for us, I think.
Be a good thing to speak with the consultant about too, when they speak with each individual board member about where they want to see the organization go. And we have in the past done that whole day retreat, and that was really valuable for that board in the past and the organization.
Yeah.
To help sit down and to spend an entire day and just think about where we've come from and where we're going. And I think some degree of pruning, as you're describing, I think is part of that process. So I think it's important for this board to do that. But thank you. And any other comments from board members? Go ahead, Supervisor Doe.
Chair, trying to balance between what we need to do as an organization moving forward and the kind of timetable coming up with recruitment. And because this board, the term is up in a year from now. And we have to start, the board of supervisors would have to initiate our process and then start recruitment within the next 4 to 5 months. That means, a lot of the timetable that we have for the rest of this year will fall right into recruitment, which will seat the new board about 11, 12 months from now. I would hate for us, we need to continue to move forward as a board. We need to have direction, I get it. But that's why I've been pausing. You looked at me and it's like on the spot, I don't know which way to go. So I leave it up to the board. But that is something that it will be coming up. And the new board will probably want to look at its own strategic plan. So my question for you maybe is, with what we have come up as a strategic plan together, this board, 2 years ago, do we have enough to carry us through to, say, early to the middle of 2020?
Certainly, we could continue to operate with our existing strategic plan for another year. So
we're not going to run out of goals and things to work on, right? Okay.
Yeah.
And in terms of the possibly starting to put together the system of care that I mentioned earlier, we have enough here for this board to work on.
Sure.
From now until the middle or early part of, it wouldn't be the middle, it would be the early part of 2020. We do?
Yes.
So with that in mind, I'll leave it up to the board as far as what you want to do.
So I think what I'm hearing is delaying the start of the planning process and start it with the new board. And until then, we just continue with our existing strategic plan. And we have we're pretty clear on what the major priorities are.
I would think so. Just because for the next year, a lot of things will change. And I think the landscape will probably change also as far as the responsibilities that CalOptima will either take on or be placed on us. And so the new board will want to deal with that. And I think holistically together with all the other efforts, right? Homelessness, mental health and such.
Mr. Penrose.
Thank you, Mr. Chair. I think it's an important question to ask. I've been on this board for about 8 years. The date that you're referring to will be the end for me. I'm not sure what the rest of the board is thinking or will be doing beyond that. In the time that I've been on the board and Chair Yost has referenced earlier when he was on the board, we've gone through a series of planning sessions and various strategic plans. Correct me if I'm wrong, the strategic plan that we just reviewed is a slight modification of the one that existed prior to that. So it has been 5 years, 6 years since we really, as a board, put our heads together and thought about the future. One of the considerations that we've wrestled with in the past with this exact question is, if you wait and let's say there's significant turnover in the board, a new board comes on, you need a period where the new board is given time to be educated and oriented to CalOptima before jumping right into strategic planning. I'm one board member who has some ideas about the current construct of the strategic plan and how it can be improved or enhanced. And I'm worried that if we don't redo the strategic plan, we're going to fall into the trap that Director DeLuigi described, where we just add on. We don't take anything off the plate, or we don't really identify what the priorities are. And so I would advocate for at least a modified opportunity to do some strategic planning. And in the timeline that I think I just heard, it would be relatively quick. We'd come out of it with something that you can implement in July and move forward. But I think my belief is we'd be remiss if we just tried to continue the current strategic plan. I think there's a lot that's changed in 5 years. There's a lot of opportunities that we could be taking advantage of, some of the things that we've talked about today. So my bias would be that we should engage in a process.
May I, Mr. Chair?
Let's let some of the board members speak and chime in. Everybody here has an equal voice, and then we'll come back to comments again from Supervisor Doe. Go ahead, Director Berger.
I remember from our last quack meeting, Dr. Nguyen said, it's finally starting to click. Yes. That was, we're on our, marking our second year halfway through. So I'd like to perhaps entertain both possibilities of a blend, of a modified plan, because it's an ever-changing world. And I think that just like us, the next group of board members, it will take time for them before it clicks. And we're right in the midst of it. We understand it, we feel it, we live it, we get all the comments from the communities. We have something to say to set the stage for the next group. And I think it would be a huge miss if we don't act on it fairly quickly on some of those brewing issues today that need to be part of the strat plan. So maybe it doesn't have to be full-blown, but I can only imagine this is going to be cyclical. 2 years from now, it will take 2 more years for the new board then to click, and then 2 years for them to adios. So I think it's one of those things that we have to be really thoughtful about the process and to make sure that we go with the flow and the momentum that it deserves to actually start making some difference.
Other board members, comments?
I think that the things we're talking about are very real, but I think that, again, these are issues that most boards have to deal with. And I don't know that, and we have to make our own continuity. So I don't know that we want to allow some of these things that are going to be inconvenient and difficult to blow up our strategic planning thinking. So for all the same reasons you're just saying, this is going to continue. It's always going to be this way.
Yeah.
We're always going to face this sort of thing to a greater degree or a lesser degree. And it depends upon the turnover. Got a lot of turnover, you turn over the whole board, well, maybe it makes sense to wait. If it's gradual though, if it's incremental type thing, then you're going to have some folks that aren't, that are coming in new. I would Well, just from my own perspective, I would agree with what you just said, and that is that I certainly would have dug into the task of a strategic plan early on in my tenure, but I surely wouldn't have been able to contribute to it in terms of the quality of contribution based on experience that I could now.
Supervisor Doe, you want to speak again?
There's great value in what you all have said. I think a chance to almost like debrief your collective experience and knowledge in putting together a plan for the future is good. Where I get a little held up, and maybe it's just a question of process, is the last step says to seek approval from the board of directors in terms of this strategic plan. And that's my only reservation. I don't want to put the new board in a position, if this board approves, right, a strategic plan, that somehow within months, if they want to do something different, that it becomes an affirmative step to overturn a previous board's approval. That's it. But if we go through the process and we just take it, knowing that it's going to be at the end of the year, 2 or 3 months away from the new board, that we just know that could then be a plan that we can maybe pass on as recommendations, as opposed to a formal approval process. This is the official strategic plan for the next 2 years.
Say, having served on this board twice now, I totally sympathize with what Dr. Nguyen said, that it takes a while to understand how this organization works and to understand the community, to understand our role, to understand our roles as a board. And the idea that a new board is going to come in with all of their responsibilities, and the seats are fixed now until 2023 on the board in terms of the seats, not necessarily who is in them, but those seats are fixed. And the idea that it's going to change rather dramatically, I think that this board is a very high-powered board. It's what it's intended to do. And I think its responsibility is to leave the organization, as powerful and as strong and as forward-thinking and as vibrant as it is right now. And I think in order to do that, you have to have a strategic planning process. And the idea that we're going to stop and wait until a completely neophyte board potentially comes in abdicates our current responsibility and is absolutely not what we ought to do as board members. So from my perspective as chair, I think you need to march ahead, and this board needs to do what it can do to leave this organization providing its mission to the greatest ability that it can. And if something happens to that board, then, so be it. But as long as I'm sitting in this chair and on this board, I'm going to do my best to make sure that this organization continues to do what it does. So that's my own feeling personally. Okay. Supervisor Berger. I'm sorry, Director Berger.
You say that all the time. I'm getting used to it. And I think as board members, strategy is what we own every day anyway.
Yeah.
For as long as we're on this seat. So just like any other strategic plan of any other company, you don't want to just kind of like set it aside and it's shelved. I think we're very, very active and really looking at making sure that our tactical, projects are aligned with our strategies. So that's always going to be work in progress anyway. So I have a lot of faith that the next group of people will carry on and then rebuild or add on as we go. And I've always kind of looked at our role as really noses in, but hands off, which means that if we're living the strategy every day, then we should keep that motion. It's our obligation. So.
Yeah, and I always view that, the job of any leader is to groom the people following after you and to make sure that you're leaving them a healthy organization and the skills to take care of it. It's more, to me, of passing a baton than it is holding that baton forever or sending it wherever you want it to go, but more where your board wants it to go. But with that in mind, any other comments from the board? Okay, on to item 23.
If I can,
Go ahead.
So what I'm hearing is proceed. Maybe less the approval, but proceed. So
the board as a whole will make that decision when we get to it, if it's appropriate or not. But the board itself will have the power to make that decision as it sees fit.
Okay. So by proceeding, I would the immediate next steps would be I'm going to select a consultant. We're going to reach out to your board members to book a date for that strategic planning session now, because it's a full day and you're all really busy people. So we're going to look for a Friday or a Saturday in the month of May. So that request is coming from Suzanne. And then once we have that date set, then we can focus on getting the speakers at the federal, state, and local level. So, we'll go ahead and proceed with that.
Yes, absolutely.
Thank you.
All right. And on to item 23. And thank you for your patience, everybody. We do have one speaker who wants to speak on this item, Bill Barcelona, but we'll speak after, go ahead. After you give a staff presentation. Go ahead, please.
Thank you, Mr. Chairman.
Thank you for your patience, too.
Oh, absolutely. Good afternoon to you and members of the board. My name is T.C. Rohde. I'm the Director of Regulatory Affairs and Compliance here at CalOptima for Medi-Cal. And I wanted to provide a brief overview of the Department of Managed Healthcare's rulemaking efforts related to general licensure requirements for healthcare service plans. Okay, so the structure of this, I wanted to provide a brief overview of the content of the proposed regulation itself, a little bit of an idea of what the process looks like for rulemaking, some of the statewide response to this, and also some analysis on potential impact to CalOptima and its health networks. So in short, I'll start at the bottom of the slide actually here. The proposed rulemaking would create a requirement that any entity that takes both professional and institutional risk, this is global risk, from a full service healthcare service plan such as CalOptima, would need to apply for licensure, Knox-Keene licensure with the Department of Managed Healthcare, or for an exemption from that licensure requirement. The regulation defines a number of pertinent terms: global risk, limited healthcare service plan, restricted healthcare service plan. These are all things that are important in defining who would meet these requirements. With respect to timing and DMHC's rulemaking process, this has been something of a lengthy process. It began in October of 2017. The DMHC published its initial draft of these regulations, and it went through a series of public comment reviews and revisions. In late summer of 2018, the DMHC decided that it was ready to advance to the Office of Administrative Law. The OAL actually rejected the proposed regulations on a few grounds, mostly on a clarity standard related to the exemption process, and also on some procedural grounds. So it went back to DMHC. They had a chance to work on the language, put it back out for a fourth public comment period. We'll talk a little bit about that in the forthcoming slides. That all happened, and DMHC resubmitted the regs to the OAL. The OAL confirmed they received them on January 30th, and that they will make a decision regarding those regs by March 5th. This last bullet is just that the regulation will be applied prospectively. So it would apply to any contracts issued, amended, or renewed after the date that would be determined ultimately by the OAL. So the fourth comment period was a significant comment period. I think typically in rulemaking proceedings, you see the number of comments and the level of interest maybe kind of dwindle over time as folks' comments are addressed and their concerns are resolved. In this fourth comment period, the DMHC received over 80 pages of public comment from some very notable organizations you can see on the screen, including one of which I think there's a representative from today to provide public comment. All that to say that there's a significant level of interest statewide in this issue. It's not just an Orange County issue. It's not just a CalOptima issue. There are myriad impacts to folks throughout the state. A common theme in the comments was that the exemption process itself, the criteria that would need to be met, and the process itself still lacks clarity. That's the very thing that caused the OAL to reject the regs. And, you know, if folks don't know, or there are numerous interpretations that can be had about what the standards are where you would or would not qualify for an exemption, folks posit that that is still unclear. And ultimately, the OAL will decide if, you know, the regs are concrete enough and clear enough to be moved forward, or if, in line with many public commenters' opinions, they are not. I guess the only other thing I forgot to say here was the assertion is that it could lead to a subjective decision-making process on the part of the department for whether or not an entity would receive an exemption. So that is an assertion that was made from among numerous public commenters. LHPC is an association, Local Health Plans of California, one of CalOptima's trade associations that we belong to. In partnership with them, we did submit comments, public comments, and really around one very key issue, and I'm going to read it and then try to kind of break it down. So we sought clarification that entities assuming global risk would be able to seek and be granted a restricted healthcare service plan license or an exemption from the requirement for that license, regardless of whether the full service healthcare service plan is licensed or, as in CalOptima's case, with respect to Medi-Cal, has a statutory exemption from the licensure requirement. So it's a mouthful, but can the full service healthcare service plan be like CalOptima, where we are appropriately licensed for all lines of business that require a license, but if we have a statutory exemption while we are still a full service healthcare service plan, can we have delegates who have Knox-Keene licenses in their own rights, these restricted healthcare service plan licenses? Our opinion is absolutely yes, we can. DMHC didn't directly answer this question, basically because it didn't immediately pertain to the changes from the last version of the regs to this version of the regs. We have tried through separate avenues to also obtain definitive clarification from DMHC on this, but because it pertains to a specific plan during the rulemaking process, that's not something that they're willing to speculate on. And those types of determinations would need to be made after the regulation is final, and potentially by those entities applying for licensure or an exemption from licensure so that DMHC can see all of the submitted materials and make their own determination. So on to the impact to CalOptima and our HMO health networks. Just to reiterate, CalOptima is a full-service healthcare service plan. We've had a Knox-Keene license with the DMHC since the year 2000, but it doesn't apply to all of our lines of business. So it applies to OneCare and OneCare Connect. We have a statutory exemption for Medi-Cal. We also do not have a requirement for PACE. And just an interesting note here, DMHC in its response to the first round of public comments said that the regulation does not affect existing licensure requirements or exemptions for Medi-Cal entities, which we interpret as that has no bearing on our licensure requirements. CalOptima health networks that operate in the HMO model.
CalOptima's licensure requirements.
Yes, sir. CalOptima's health networks that operate in the HMO model already have a requirement to obtain Knox-Keene licenses, and they do have Knox-Keene licenses. Do not expect a change to the status of that. This gets more interesting when you talk about the PHC and the SRG model. So for the physician health consortia and the shared risk groups, those models do have risk pools. And a lot of this will ultimately come down to whether or not DMHC considers those contracting arrangements to constitute the assumption of global risk. So the PHC risk pools have a limitation on physician group downside risk. The SRG risk pools include forgiveness of risk pool deficits allocated to physician groups. And I think that in the terms that DMHC has put in the regulations, they'll consider a number of factors when considering exemption requests. And part of that could be the level of global risk that is assumed if they do determine that to be global risk. And this is a relatively limited level of risk sharing. But ultimately, we don't know what DMHC will say about that, and they very well, as I said, could just say, submit it to us and we'll make a determination on our own. We're not going to speculate in terms of what we may or may not see. Yeah, I think I would just say that we have posed that question plainly in a number of formats and creative ways and received the same answer, that they're not going to speculate on that. Lastly, additional considerations, and this is more just for the interest of the public and our health network partners. We recognize that health networks have other business than CalOptima, so they may have independent filing obligations tied to those lines of business. So it's important that folks consider this not just as an issue with respect to their relationship with CalOptima, but their whole book of business. Lastly, I'd just say that we'd be happy to continue to provide updates on this as the board would like, and we'll continue to work with and update our health network partners. So with that, that's the conclusion of my remarks. I can take questions now or follow up. Yes, ma'am.
Let's let our public comment person speak, and then we'll see if the board has questions of you. That'd be okay. Thanks. Hi. Mr. Barcelona, please come on up.
Thank you. Bill Barcelona from America's Physician Groups. Thanks for giving me some time today. That was a great summary of a very murky regulatory situation. And I'm glad I don't have to give it to you. So I'm glad we got that out of the way. Our concern is this. Having been a former chief of the licensing division at DMHC and a deputy director, as well as a Knox-Keene attorney for 17 years, this regulatory process is unusual in the history of the department in terms of its lack of communication, its lack of clarity, and the ambiguities that are now posed to the entire risk-bearing marketplace in California. And it extends far beyond just these arrangements that have existed over the last 25 years between CalOptima and its networks. It expands even into newer levels of risk-based and value-based payments, such as bundled payments, and whether or not surgeons who accept bundled payments with hospitals will have to seek exemption from this process. But what we know is this: the regulation does not allow for providers to seek exemption for anything beyond the level of risk that they're accepting that's been defined as global risk. In other words, you can't go to the department and seek an exemption as a provider because you are attempting to take global risk from a non-full service Knox-Keene plan. And so if the department determines that CalOptima does not meet that criteria, that the statutory exemption does not apply, we're stuck. And we won't know this until after the regulation is adopted formally. And of course, then it'll be too late. And this regulation was submitted about 3 weeks ago. The OAL could issue the decision any day. And so the need for advocacy is immediate, and we would appreciate any assistance that the plan can give to us as providers as we go in to try to explain this to the new administration that's now in charge of this department and perhaps even the legislature. Thank you very much.
Thank you, and thank you for your patience. I'm sorry you had to wait for a couple hours.
That's all right. Are there any questions that...
Maybe have questions for Mr. Barcelona. I'll allow that. Go ahead, Supervisor Doe, go ahead, please.
Have you worked with any of the local delegation here? And anything we can do to help maybe talk to them and they can then contact the department?
I do think that would be helpful if you would do that, yes. We've
Absolutely.
reached out to people in the legislature. We would like to address it with the administration. But as we do that as providers, we want to be assured that the plan is backing up our advocacy as well, and that we're in lockstep on our advocacy efforts.
Is this where we are, is it more department driven or is it more administration driven?
No, it's driven by the department. This was undertaken in the previous Brown administration, and so now that the Newsom administration has taken over and you have new people in some of the higher agencies and the governor's office, for example, there may be opportunities for us to ask for some further consideration here before the OAL issues its decision.
Is there any way for us to maybe decipher possibly a new direction by the new administration?
Through conversations with them, yes.
No, I'm just thinking, do we have anybody that has given us an indication which way Governor Newsom may lean on this issue?
No.
It's probably too
This is
new.
very arcane law.
Yeah.
There's very few lawyers in California that practice in this area, and I can tell you that there are very few individuals in the administration that have any familiarity with restricted license or global risk.
We have a new senator, Tom Umberg, who is a lawyer and
Yes.
who works pretty closely with the governor as well. So
Yes,
okay,
that could be helpful.
Okay.
Thank you.
Luigi, go ahead.
And it relates to some of the ideas that Bill has just brought up. You know,
Did you have a question specifically for Bill, or do you want to have Mr. Rohde come back up, or?
no, it relates more to what Bill was. It's not a question specifically of Bill. So if there's other questions of Bill, I'll defer what I have to say.
Hey, is there any other board members have a question of Bill? Go ahead.
Bill, do you have a backup plan? Let's say it doesn't work out. You going to take it to the legislator? Yes. Oh.
Yes, we will.
Yeah, I think there's a legislative vehicle that's in process, potentially. Go ahead.
The question is, do we have a backup plan?
Yeah.
Because we're the ones that are going to be on the receiving end of this, as well as other folks. And I don't remember if Supervisor Doe was at the. We had a recent meeting where we discussed this, and one of the things that I thought was clear when we went away from it was that we were going to engage in the advocacy process. As Bill says, this as a regulatory process, this is different and unique in and of itself. But even with regulatory processes, you can make comments. But when you have a situation where we're not getting answers, nothing that's being said by the department is in any way assuring from my standpoint. I don't know if you've read this fourth round comments, but it's really interesting. I mean, we're all very busy, and I know that it's a lot, but it's some very interesting reading. The comments are excellent. They're appropriate. The questions are very clear and direct, and you don't have a regulating agency that in any way appears to be willing to answer. And if they would answer some of these concerns, maybe they wouldn't have, now it depends upon how they answer, but they wouldn't have as much anxiety that's out there. My concern, especially as I look at the March 5th date, TJ's presentation, is what are we going to do? And I honestly felt we should have started already. I think as we look at this as an organization, I think we take a rather narrow lane approach, and we take a very passive position. And I don't want to get into what all the basis of that is. I simply have seen and heard enough where there's no way that we can predict what the outcome of this is. We could sit here and roll the dice and say, oh, gee, it sounds like a couple of comments may go our way. But waiting for that action to be taken before we act is not a very dangerous perspective, because if they go in a direction that's counter to our interests, we're going to be in some pretty deep trouble. And I don't even think we've done the financial assessment to even know just how egregious that could be. I think that there have been a couple of suggestions on advocacy effort. I think Bill's are good ones. I think the idea that we do have a new administration here, and it makes sense to, at least try to educate and to get and to make it clear in terms of what the concern of the broader healthcare delivery population is, systems like ours, et cetera. Supervisor Doe's comment on the delegation is imperative. I kind of had a side discussion with that last meeting on the idea of we need to make the rounds with our delegation and make it clear exactly what we think of this and exactly what our concerns are, and that our concerns are not being addressed. The other thing is that the California Hospital Association has begun to think about direction they can take as well, which would be potentially preemptive. And that is the possibility of dropping a spot bill in that would address many of these concerns, many of the questions that all of us are raising. I think that's a positive direction. We need to be engaged in all those things. We, CalOptima. There's immediate risk, I think, that we have a sense of. But the thing that I'd also add to this that concerns me is the broader, longer-term risk should these become regulation and law. CalOptima was founded, County Organized Health System, as an entity that could step out there and innovate right here on our own. We're close to the community. We're part of the community. We have the ability to work closely with all the providers. We have been at the vanguard since the development of CalOptima, but particularly more recently around the issue of value-based payment contracting, risk development, risk appropriate contracts and approaches in ways that was very considerate of everybody involved. Last thing in the world we as an organization want to do is place one of our plans into an undue risk. It needs to be appropriate. So we run the risk of losing that sort of thing. We are, I would contend, we are chartered to be an innovator. And my sense is that this is a tremendous overreach by a regulatory body. And it will have a very chilling effect on not only organizations like ours, but especially the organizations we're working with, our providers, our partners. And I don't think we want to be put out of that business. As we had an agenda item on the agenda earlier today where we're talking about this plan, this community effort where we're going to hire a consultant to help us with. You know, these are the kind of things, that's the information we want to get, but we should be thinking about what's the next generation of risk contracts? What's the next generation of approaches? Where do we think we could go? Right now, we can do that unhindered. We can move out and we can be innovative. We're called upon to do that. With this sort of regulatory effort, I doubt that we would be able to do that sort of thing. I think we have to, that's why I say CalOptima has, what are we going to do? We have to protect against that because I think it's a significant infringement on what our autonomy and ability to do things have been in the past. So we need to move post-haste on advocacy efforts. I'm very supportive of the recommendations and the ideas that Bill has communicated to Michael in his letter to CalOptima. And there's a couple others that we mentioned. Definitely get the delegation attuned. But most importantly, get these players together. You guys get together and begin to think about, okay, here's the approaches we're looking at. We're potentially get into that legislative effort that CHA is likely to sponsor. Those are things that, and again, if there's the ability to pull back on this regulation and let some more cooler heads prevail in terms of a smarter approach, that would be ideal. So I think that's where we are. We need to think about what we're going to do.
You had some comments or questions for Bill.
Thank you, Bill. I do have a question for you. And sorry for not thinking of it earlier. If we could put it on slide 4 of this presentation. There's a list of entities that are engaging directly at advocacy. And you said something that got my attention right at the end of your talk where you said as long as our arguments are aligned or something to that effect. Do you think of all of the entities listed here, do we have alignment?
I think we do. The basis of this regulation, it's important. It's important to have a regulation that governs how restricted licenses work in California so that the market knows who should apply and what conditions under which they should apply and how far it should go. We don't want to see the regulation scrapped. We just don't want the regulation in terms of its overreaching and ambiguity to scrap the 25-year relationships that we've had with this board, with this plan. And that's the problem. And I think all of these organizations, when you read the 80 pages of comments, we're all saying the same thing. We're all concerned at the level of overreach. Now, some of these don't apply to the CalOptima relationship specifically. This is one area of the overreach in the regulation. There are others in the commercial ACO and the Medicare ACO sector that are very troubling as well. And those people want to come into this advocacy effort as well. But in terms of Medi-Cal plans, unfortunately, you are the only one who's affected by this regulation at this point in time. Because you don't possess a license for the Medi-Cal business, you have a statutory exemption. The other plans hold licenses, and so any global risk relationships that have developed over the last few years and those with those organizations would not be affected. The expansion of the regulation into these other areas like the risk pools, that sort of thing, that could affect arrangements with those other Medi-Cal plans. But in terms of this regulation killing what you've had in place in terms of global capitation with restricted licensees for the past 25 years, you're really the only one who's affected in that way.
Thank you very much. Also want to bring Michael into the discussion. You, if I'm correct, you're the chair of LHPC currently, right? CalOptima is a member, and you're not only on the board, but you're the chair.
Right.
Can you talk about LHPC's advocacy? Is their message any different? Is there, are they representing all of the, because of the issue Bill just brought up, do they feel like CalOptima is standing out, or how is that dynamic playing out?
So CalOptima's been very active through the regulatory process, through the 4 comment periods. It's just instead of making our comments as CalOptima, we've made our comments as LHPC so that we could leverage the 16 public plans. One of the very first comments we made through LHPC was, this idea that Bill has described, that we're on the DMHC website because the regulation says any entity, think health networks, that take global risk from a full-service health plan, think CalOptima, must apply for Knox-Keene license or exemption. So the concern has been CalOptima is not a full-service health plan. On the DMHC website, we're listed as a full-service health plan. Through the first public comment period, we raised the question, and the response from DMHC let me look here. Was the proposed regulation does not affect existing licensure requirement or exemptions for Medi-Cal entities. And then through informal channels, we called DMHC and said, "Are you trying to blow up the Orange County model?" And they said, "No, we're focused on ACOs. This is not about CalOptima." Now that's informal. We don't have that in writing. So in our subsequent comments, they were all about idea of global risk. And as Bill shared, DMHC's stated purpose is to license ACOs. They license hospitals, they license health plans. That's an entire industry with 2 million plus Californians that they don't regulate. So that's the purpose. But as Bill said, the way the regulation is currently written, it has a broader reach, and it would have some unintended consequences. Capture our networks, require that our networks get Knox-Keene licenses or seek exemptions. So there's a lot of interest from our networks, reasonably so, that, well, if you're focused on ACOs, then can you just confirm that we would be exempted? What is your criteria for exempting entities? And that's where the department has provided no clarity, and there's been growing frustration, and the comments grow. And almost all of these associations have been consistent. They've asked the question different ways, but consistent with this regulation lacks clarity. None of us understand what the exemption criteria is. So as Bill shared, now we're looking at fourth comment period close in December. Now this regulation was sent back to the OAL, Office of Administrative Law. The OAL will make a decision by March 5th. What at least LHPC and some of these different associations are talking about is there are two possibilities. March 5th or before, could happen tomorrow. The OAL rejects the regulation. DMHC has to go back to the drawing board, make revisions, hopefully clarify things, send it back up. You would assume they would send it back to the public comment period and then it would go back to OAL. That's one possibility. The other is, let's say that in spite of the 80 pages of extensive comments from the entire industry, the OAL approves it. Then the associations are talking about, and there's already draft language. CalOptima has been given a copy. The draft language as we see for the bill would definitely exempt our health networks based on the contracts they have with us, based on our contracts, from triggering global risk. Okay, so we have let the lead association know we're very supportive of that bill. And if that decision is made on the 5th, drop the bill. And CalOptima, again, would work through LHPC because all of these associations are working at the statewide level. And there's a lot of heft when you look at these associations. I mean, that's all the hospitals in Orange County. That's all the physicians in California. That's all the physicians in California. It's all the health plans. And they're all on the same page. So our feeling has been, we've been very active through the regulatory process. If need be, March 5th, we're going to be very active through the legislative process, very active through our association. And so the question of, do we splinter away from this statewide associations and take an Orange County, and if the bill drops, that's when we're going to go SWAT on our delegation. We're going to make sure they all know you have to support this bill, okay? But the question is, if this big momentum is moving that way, do we take a small Orange County contingent compared to this statewide effort and say, let's go to the governor's office? I guess, and I like what Bill said, because the entire association is moving forward with not to, we got to kill this thing, because I think everyone recognizes they're going to regulate ACOs. It's an entire industry. They're not going to, they're going to rate, but let's make sure the regulation is written in a way that doesn't, I like your word, overreach. And so CalOptima has been very focused on that, very active through the regulatory process. And in step with all of these statewide associations, we'll be very active when it comes time for if and when it becomes time for the regulatory process, which could happen on or before March 5th. So it's just, do we take a small Orange County group to the governor's office? Outside of this, kind of where this group is moving. Yeah.
Thank you, Michael. That's a great response, and I guess I'll just conclude my comments while I have the floor and say I don't think it's common that all of these agencies are aligned in their messaging.
That's true.
And so to have a situation where we have all of these agencies this is representing healthcare. This is like healthcare having one voice. It doesn't happen. And to put all of our weight behind that, as Director DeLuigi is suggesting, is great. I think we absolutely need to be strongly supporting, and through LHPC, as you're saying, let them be our voice, and aren't making all of the arguments that when they're standing in front of the folks in Sacramento, they are representing the entire state of California. They're not just representing one county or one health plan. And so that might be a little bit of a difference there, but I think if this group of agencies is willing to stand and make an aligned argument, let's not get in the way. Let's not try to go around it or get in front of it, or I don't think we have to be the spokespeople here. And then the last point I'll make is we know that Governor Newsom has an aggressive agenda with healthcare. This may be a dress rehearsal for bigger things to come. If we have alignment on an issue with this group of agencies now on this issue, and we have other healthcare related issues that are going to come up, maybe this is an opportunity for all of these agencies to see how effective we can be when we work together.
Shuffle.
So a little historical perspective on this issue. 25 years ago, when the then Department of Corporations, which is the precursor to the predecessor to the Department of Managed Healthcare, looked at this issue, they had a very different view of what global risk meant back then. And without belaboring that point, because it's a very technical point, they coincidentally issued their first limited Knox-Keene license in '95, and coincidentally, CalOptima, then Optima, started doing business with essentially the same risk-bearing physician hospital consortia that they do business with today. Back then, the Department of Corporations didn't consider those arrangements to be particularly problematic or abusive or suspect risk-sharing arrangements, so much so that they honored the exemption that's been in the California statutes long before CalOptima. Optima was created by the County of Orange, and said, you guys take care of it through your county organized health system, and you've got great counsel, you've got good stakeholders, do the financial analysis, do everything else. We're going to stay away from that whole process. And that, in fact, is what happened back in 1995, and that is what has been the policy of that department until today, with the advent of this regulation and the possibility that it could be approved by the OAL, very, very soon. So we're dealing with a generational change in the approach to management of risk-based healthcare delivery in California. And with this particular county organized health system that we're stewards of, here, all the staff, all of the board, everything else, and have been for now a quarter of a century, we're faced with what do you do in the in the face of that pretty radical change in policy so far as I'm concerned. So in my professional practice, in my experience over the last 25 years, I'm not aware of frankly, any other local health plan that could be as adversely impacted in a number of different ways as CalOptima. So maybe there is an alignment of interests that I'm not seeing, and maybe there's a way to make that happen so that we could leave here knowing that our interests would be well supported by the association, because I'm a big believer in professional associations and industry associations and things like that. But my view is, unless I get, as a board member and as someone who's participated in this particular agency and the department's approach to regulating global risk over 25 years, I would feel a whole lot better if I knew that that association position was going to be precisely and categorically representative of CalOptima's position as well. Because frankly, I can't think of another local plan that is in the same position of having to deliver as much care to so many beneficiaries, having to shift as much risk as this organization does to accomplish that at the medical loss ratio that we do. So while I would agree philosophically with the comments I've heard from Mr. Penrose and others here today, I would want more assurance that that advocacy and that case and that position and the reflection of 25 years of experience of this agency, other agencies throughout the state, was as well and properly represented as possible. If that can happen through the local plans, and I can get some comfort for that, I would certainly support that. Otherwise, I wouldn't endorse spinning off in another direction. I wouldn't endorse going around the plan. I would endorse making sure either by our presence in the process or by our participation with the plan before that advocacy takes place, we knew that this agency's experience and interests would truly be aligned and truly be as well represented as possible. So it's a bit personal for me. It's a bit professional for me, having watched this whole thing unfold over the past quarter of a century. But that would be my considered professional board member and personal recommendation for the board at this point.
So you have a specific recommendation. I mean, our CEO, Michael Schrader, is head of the LHPC, and so he is conveying the desires of that organization. It seems like it'd be hard-pressed to find a person or a vehicle that would be more in line with the interests of the organization, given he's our CEO as well as the president of the LHBC. I mean, do you have another recommendation? Are you recommending that the board take a more active role? What is where are you going with this specifically?
So at this point, I think that that's certainly one convenient and appropriate way to approach the advocacy. I think that we could consider other ways to augment the effectiveness of that process. And I can't give you a specific approach at this particular time, but I think with, given some thought and reflection, there may well be a way to augment that process that would hold us in better stead.
Mr. Chairman.
Sure, go ahead.
Rather than delegate it to an association that Michael does a fine job attending, participating, and leading.
To Luigi.
Yeah, Mr. Chairman, I think, and maybe Bill can answer this, but I see us, I don't want us to confuse something. These associations are all standing together for each of these entities in the regulatory review. That is, they're filing written comments. That's not advocacy. When we talk about advocacy, we're talking about trying to get on a footing where we at least have key decision makers in the state understanding and thinking about the kinds of issues we're raising. And right now, it's appropriate that they all file their written comments, and I think they've all done a good job. But those are just written comments. And the audience is the Department of Managed Healthcare. And they're not even willing to, like I said, if you look at these responses, they're very, very rigid and quite cavalier. They're not answering it. They don't need to. And when we talk about advocacy, we're talking about moving on. This has run its course just about, unless the Office of Administrative Law says, okay, we're persuaded by all the comments here, and we're not going to adopt these regulations in the law. And I'll just go back to what we said earlier. That's a big, big risk.
What?
And so, it's we sit back and wait for that, and if that happens, then it's already become law. And believe me, I think passing legislation after the fact is a little bit more difficult to make happen than certainly trying to get that message out there in an advocacy fashion ahead of time. Getting that to some key decision makers now, right now.
So what is your specific recommendation? Or first, I have one. What is your specific recommendation?
I appreciate that, Mr. Chairman. I'll answer.
Yeah.
But Bill, am I wrong? I mean, because I see that the, certainly the American Physician Groups, I see the California Hospital Association that are thinking about moving forward in advocacy. These, I mean, do you see them all working together on an advocacy process right now, ready to roll?
Or legislative process?
We only have alignment between APG and CHA on the specific spot bill that we proposed. We've talked to other, I'm sorry, I don't mean to interrupt. Go ahead.
No, good.
So I think, like you shared, CHA is sort of leading the way on the bill.
Mm-hmm.
And I'm glad to hear APG and CHA are kind of in alignment, because so are LHPC and CHA. There was a meeting last Friday. So I think CHA is, reaching out, is my understanding.
Michael, is LHPC committed to the CHA bill?
Give me next.
Yes, the bill looks very good.
Okay.
So it's not, again, to Lee's comments, because I agree, if we had all these guys lined up and they were engaging in an advocacy battle, which is apart from the regulatory review, this is actually working with elected officials and others and making it very clear to them, hey, you realize what's going on over here and how concerning it is.
Because is our lobbyists, our state lobbyists, are well aware of all of this and helping in this process as well?
They're aware of it, yes.
Our lobby, but you know what, when he was here last time, again, I asked about it, he didn't have a clue.
Okay.
He's not doing anything on it as we speak, right?
As we speak, he's
Right.
not moving on this yet.
What I think we need to determine amongst us is, does this warrant advocacy action?
Right.
I would contend that it definitely does. This is big stuff for CalOptima.
And then, I guess the next question is, or Nikon and Dr. Katibi has a question. Go ahead.
Briefly agree with Ron on this comment. I think this is a big deal. I think CalOptima is probably one of the most vulnerable persons at the table. I spoke with CMA this morning as well. I called them up and say, hey, listen, the person who's drafted the comments, hey, what's going on? What's the story? They're just as concerned, and I read APGs and I read the CHAs as well. They really feel like CalOptima is the one that's going to be the most vulnerable throughout the state, and they're drafting up some proposals for us as well. But that being said, I appreciate what everybody's doing, but I think CalOptima should take its stake and put a stake in the ground, and I think our lobbyists should be on top of it. That's what they get paid for. That's their job to do, and we want to make sure our members are represented, and more importantly, our health plans, because it's going to stifle innovation for so many of our health plans, for our providers, to think outside the box, and some people just might be hesitant to participate in value-based care because of this, and I think that's going to be stifling for many of our patients. So,
Just one quick comment.
Go ahead.
Thank you. We've approached the legislature on this, specifically the chair of the Assembly Health Committee. And, in those discussions, you have to remember the division of powers in government between the legislature and the executive branch. We were told that the legislature is hesitant to override the decisions made by the executive branch when they're drafting regulations. And so it's essential that we do have a solid legislative support for this activity, but also that we talk to the new administration as well and get their support, because often legislators will not carry bills when they know that the governor's office, for example, would just be predisposed to veto the bill.
Yeah.
And so that's kind of the groundwork that we need to lay before we drop a bill in the legislature.
All right. This is really just information. But one thing I would say is, in our professional association, what we've done with our lobbyists is we've heavily engaged in the regulatory process, and our lobbyists go with us when we go to DMHC, when we go and deal with issues of Title 22, and we don't just consider advocating for legislative bills. We consider it in issues exactly like this, and that's what they're paid for. And if they're not on the spot, I think we should do an RFP for another lobbyist because they really need to be upfront and helping us in this regard. And that, to me, would be, the direction that we ought to send them, at this particular point. And does that resonate with you, Ron, in terms
I get, sure, I'd like to I'd like to have everybody who we possibly can get engaged, who can effectively help us. But I think, Bill's first point, hold a meeting between CalOptima and APG, other interested parties. Let these guys convene.
Sure.
And I honestly thought that that's what was going to happen after our last board meeting, that they would be getting together and let them strategize on approaches. Now, I think that some of the strategies that Bill's already laid out are excellent. And again, I would add, we need to make sure our Orange County delegation is aware. Now, so we may not have key committee members. I've not taken a look at what committee assignments our guys have in quite a while. But regardless, it's important for them to have a sense of just how problematic this is for us. And then, as you say, if CHA, if APG, and a couple of these other entities are active in Sacramento, along with our lobbyists, et cetera, in making the case. But again, the strategy, I think, would flow naturally from a meeting along the lines that Bill is suggesting.
Yeah, I think that's a very natural step to go in, but also as a long time. Go ahead.
The other thing I was going to suggest, Mr. Chairman, I appreciate it. The other thing I was going to suggest, we need to be clear. We need to take a position that we firmly oppose this, so that if in advocacy efforts, if there's a discussion with Tom Umberg in some hallway where you get the chance or something like that, and we want to make sure that whoever's saying that can be sure that we're not going to back off on something like that. We should be clear that our position is consistent with the kind of things that we laid out here. We're opposed to an overreach of regulation.
Okay.
But again, I would definitely suggest that we go with the recommendations that Bill has sent to Michael, and let's get those rolling. If there's anything unique or significant that comes out of that we as a board need to convene on after that, we can certainly do that. But I think I'd like to make sure that as we go away today, we're clear that we oppose these regulations.
Okay. Mr. Sanchez.
I was just going to, Ron kind of stole some of my talking points there, but I agree with, no, I'm glad you said it, because I think, given what Scott said during his comments, I think, remembering back to the reason why Scott is on this board is exactly the reason why we need to listen to what he's saying. Sure. So I think with the considered comments that he made along with Director DeLuigi, if we're looking for kind of going forward, what is our action? I'm leaning towards that.
Other board consensus? So specifically, Mr. Schoeffel, what do you think we should be doing specifically?
I think that Mr. Barcelona's suggestions are a great start. Okay. I think we don't exclude the associations. We work with them. I think, as I mentioned to Mr. Schrader in my board briefing, the more people you get to the table who are similarly aligned, or who can be similarly aligned, and can also get some level of awareness of the depth and the length of this problem. And in CalOptima's case, I'll just add one other thing. Since 1995, I can't recall a single crisis that this agency has had, financial or otherwise, that has led to, for example, the last, I think the 2 legislative sessions ago, when there was a move afoot, and a very strong move afoot, to eliminate the exemption for COES plans altogether from the Knox-Keene Act. And it went down to the last moment before that legislation was defeated. So I only see that movement as adding unnecessary layers of cost to the system at all appreciable levels, with no discernible benefit that I'm aware of. And I think the CalOptima, with the way it's laid out with its many healthcare networks, all of whom assume some level of institutional risk, is quite unique, stands quite unique among all these local plans in the state of California. And I think we need to be very forthright and persuasive about that point.
I think that's a good point. What I was thinking of as well earlier on, you know, for 25 years, we haven't had the issues or the concerns that are being raised around these regs.
Yeah.
And we've been at, like I said, CalOptima's been at the vanguard of this stuff.
I think you, Mr. Schrader, I think you have
We've gotten a lot of
consensus
feedback and
direction.
direction. We're already planning a meeting with the health networks.
Perfect.
And our hospitals that are impacted along with APG.
Yeah.
We'll engage our a lobbyist because at that meeting we'll be talking about, do we want to approach the governor's office? So we'll include our lobbyists as part of that. The reason the lobbyist hasn't been involved so far is during the rulemaking process, DMHC cannot talk to the parties. That's part of the frustrations. None of us can talk to DMHC and say, you know, so we have to go through this public comment period. But we'll engage. We've been meeting with the health networks. We'll have another meeting. We'll include APG. We'll include our lobbyists, and we'll talk about if we should go to the governor's office.
Yeah. Last comment. Go ahead.
I just want you to raise a question maybe with Mr. Barcelona or any of the other partners we have who are still in the audience on this thing. Is there anything more that you need from us? I mean, again, along the lines of the point I just made about pretty solid position on this thing. Is there anything else you guys need?
I think this is fantastic. I appreciate it very much. As long as we have your support when we reach out to legislators and we tell them about the problem in Orange County, when they contact CalOptima to ask for a confirmation that it's received.
Yeah.
And that will help.
And we'll engage our delegation. So
Having been a veteran of a lot of political battles, the one thing that is the most important is to have a huge, broad array of people that feel the same way, that are supportive of your issue ahead of time, and that any opposition to that is minimized, are the two real keys in getting other people to make our arguments for us, because it's just a single small entity in a statewide decision-making process. We don't have as much weight, but if we can gather those other organizations, it makes the argument that much more powerful. Well, that's what Lee was saying.
And if I could just echo that real quick, I remember during healthcare reform, Obamacare, before it passed, being in Washington, D.C. with Director DeLuigi and going into the offices of some of our delegates, and they were describing the frustration. They would have somebody from the medical association come in and say, whatever you do, don't do X. And then somebody from the hospital association would come in and say, whatever you do, do X. And so they threw their arms up and they did whatever made the most sense to them. And so that's the basis of where a lot of my comments come from. And I get concerned when I see, a delegation going up to the governor's office that intentionally or not could send an opposing message to some of these other agencies. The points you're making about get on the same page before you start this activity is critical. And I know time is short, but we've got to avoid that mistake.
Absolutely. Okay. I think you have great direction. Thank you very much. And thank you for the discussion for all board members. The staff has done a thorough job on the remaining information items, including your packet items 24 through 27. Unless anybody disagrees, we can adopt those. I don't see any disagreement. And board member comments. I'll start at my right, Mr. DeLuigi. Sorry about the length of the meeting.
We've already talked quite a bit, haven't we?
Yes.
The only thing I did want to, and I didn't expect Dr. Helmer to hang around for all of our activities, but it's great to see Richard honored for all of his contributions to CalOptima. He was there at the beginning, and so he has some of the same history that some of us have who were involved in that. And he was such a key player, and it's nice to see him move on to the next chapter in his life, and hopefully he has some enjoyment in doing that. But it was nice that we had that recognition ceremony for him.
Director Berger.
I'm just looking forward to hearing more about the Whole Child Model Family Advisory Committee and their feedback.
Dr. Nguyen.
No
Shuffle. Sanchez? Okay. And I just have one housekeeping item. The board authorized the expenditure for the IGT 6 and 7, including release of RSPs for community goals. To facilitate that process, I'll be forming an ad hoc to review the proposals and present the recommendations to the board. If any of you are interested in serving on the ad hoc committee, please let the clerk of the board know, and she'll send out an email to the board members who are no longer here too.
Which ad hoc for which IGT?
6 and 7.
6 and 7.
Yes, and if you'd like to serve on that, Suzanne, the clerk of the board, will send out a notice. We were going to adjourn to closed session. However, given the person I think got the most amount of information is no longer here, perhaps we should defer that item until the next meeting. That'd be reasonable to do. Okay. In that case, we are adjourned.